Viva PLHIV sector, viva! Amandla!
Amandla, 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 amanga, amanga. Mandizibulisele apha ngaphakathi endlini. Igama lam ndingu-Anele Yawa. Ndingu-General Secretary we-Treatment Action Campaign and also the Chief Accounting Officer of Ritshidze. Andindedwanga ke apha ndinalama comrade kunye nawo ndizawuqala apha left.
Ndiyabulisa nami igama lami nguSimphiwe Xaba ndisebenza apha eRitshidze as a Ritshidze project officer. Thank you.
Molweni, igama lami ndinguNdiphiwe Bekwapi, ndisebenza apha eRitshidze as i-district organizer apha kule district kunye nase-Alfred Nzo enkosi.
Molweni, igama lami nguLuthando Sono, ndisebenza apha kwaRitshidze ndi-key population organizer yakhona.
Also phakathi kwethu sinawo amalungu omphakathi abalapha endlini and bakhona abanye ababukelele intlanganiso online kwindawo ezohlukeneyo. Pa online sinabo abantu abasuka kwi-National Department of Health, abasuka kwi-PEPFAR, abasuka kwi-CDC, abasuka kwi-USAID, including other district support partners. But also apha endlini sinaye umama ngicela unifundele kahle.
Okay, sinaye umama Dalingozi Bosiswa, uyi-manager emhlakulo CHC. Sinaye umama uPhumlo Vamela, osuka edistrictini as district host. Enkosi.
Enkosi. And also apha endlini sinaye comrade uThando Xolodorho osuka head office apha South Africa ye USAID. Thank you Nkokheli. Inhlanganiso yanamhlanje bahlali zawuzama nithethe isiqwathi but ke bakhona abanye ababukeleyo abangasivayo isiqwathi but zawuzama nifikeleleke nithethe iXhonglish, thethe isiXhosa pha phakathi ndiphinde njike ndithethe isiNgesi. Isizathu sale nhlanganiso sinayo namhlanje inhlanganiso edibanisa abasebenzisi benkonzo zempilo kunye nabantu abanikeza ngenkonzo zempilo kumphakathi, including abantu abaxhasa inkonzo zezempilo eMzantsi Afrika. Ngoba singumzantsi Afrika sizawukhumbula abahlali kude kudala phaya besinengxaki apha eMzantsi Afrika yabantu bakuthi bebesweleka mhla nezolo, apho imingcwabo ibibakho even phakathi evekini, abantu bakuthi besweleka bebulawa zizigulo ezingqamene kunye ne-HIV. And ngela xesha libe lingekho ichiza lokuthomalalisa okanye ukuyinyanga ugawulayo. Kubekho imibutho efana kunye no-TAC neminye imibutho eyathe yona yaphakama yamela amalungelo abantu. Siyakhumbula ngelo xesha ke umuntu ebephethe ezumongameli welizwe ibingutata uThabo Mbeki, uMinister we-Health ingumama uManto Tshabala Msimanga, esithi utata uThabo Mbeki i-ARVs zi-toxic for bazinikwa abantu ziza kubabulala, esithi umama uManto Tshabala Msimanga abantu abaphila kunye negciwane likagawulayo badinga i-nutrition mabanikwe igarlic nebeetroot, babe abantu besweleka. Kwela xesha ke kube kukho le ngxoxo mpikiswano abantu esithe sabaluza eMzantsi Afrika by more than 300,000 and more. Yaba imibutho efana kunye no TAC, no COSATU, namagqwetha, kunye neminye imibutho yasekuhlaleni eyathi yaphakama yathetha ngelizwi elinye inyanzelisa urhulumente woMzantsi Afrika ukuba ube kanti ukhupha amachiza okuthomalalisa ugawulayo. Zange ibe yinto emnandi leyo, kwakusiliwa, kungenwa kuphunywa kwiinkundla zemithetho, kutoyitoywa, bebanjwa abantu bedutyulwa. I still remember nam ndadutyulwa ngapha eFrontier Hospital 2005 silwela for access to treatment for people living with HIV. Siyakhumbula after ANC imremovile uThabo Mbeki iye yafaka uJacob Zuma, kulapho siye sabona khona abantu abaninzi bakuthi under uMinister Aaron Motsoaledi abantu bakuthi be-initiatwa kwi-antiretrovirals. As I'm talking today, eSouth Africa sinabantu abayi-80 million abaphila with HIV, and kula 80 million, about 5.8 million people are on antiretroviral treatment. And baphila lives as normal. And if as a country we had listened to AIDS denialism that was perpetuated by the previous government, today besithetha about 5.8 or more people who died of HIV-related illnesses if ARVs were not made available in our public health establishments. As we are talking today, as much as we have many people who have been initiated on treatment, but as in South Africa, we are not doing well on retention to care as well as on adherence. Many people who are initiated on treatment, they disengage on care. And nobody cares to understand why people are disengaging on care. Always, blame is apportioned on the users of the healthcare services. As the country yaza ne-initiatives ekuthiwa ngo-Welcome Back program. Yaza ne-programs ekuthiwa ngo-CCMDD program. But as we are talking now, as uMzantsi Afrika apho sikhoyo, South Africa has a new guidelines for antiretroviral treatment. Ezithetha ngezinto ezininzi ezi-improvement, including ezithetha about o-CCMDD, apho ethi abantu aba-collector it, aba-stable kwi-treatment, aba-collector i-treatment yabo from kuma-external pickup points. That treatment must remain there for 28 days. Ingabi songu-7 days ngoku kwenzela uba ibuyiselwe eback. Abantu abaninzi who are living with HIV, gays, lesbians, sex workers, people who are using drugs, men having sex with men, and many people, when they go to our clinics, they are being stigmatized. They are being discriminated. They are being made to feel like they are nobodies. Is data zabo ziyadiscloswa esihlangalaleni, izigulo zabo. Abanye xa beyofuna i-services ezifana kunye noma termination of pregnancy, xa beyofuna i-lubricants and other services that are related to their health, kuhlekiswa ngabo eziklinikhi. Athe engenile umuntu ezofuna i-lubricant, unesi ahambe bezomnye unesi athi khawuzobona nangu lo bhuti uzenza umuntu ongisisi. Athi umntana omncinci odlwenguliweyo ongakhange az-invitele rape because of a pregnant, afuna uterminate i-pregnancy aye eklinikhi. Eklinikhi afike pha ashunyayezwe ukuthi termination of pregnancy is ungodly, akazolingena izulu. Uthi xana uyi-gay or lesbian uya eklinikhi kuhlekiswe ngawo, or ungumuntu ophila with i-HIV kuhlekiswe ngawo, even when xana you have missed i-appointment you collect medication yakho, nobody cares to know uba kwenzeke ntoni kuwo. But on the other hand, sibe siyazi ukuthi ii-clinics zethu zincinci. Xa kunetha simaphandle and siba exposed emvuleni. and sima more than 4 hours. And as a result, so omunye umuntu decide ukuthi I'm not going to collect treatment yami xa kunetha because ngizaba manzi ngizawuya eclinic xana imvula ithomalele. Xa usiya the following day uyathukwa. Ufike ekuseni eclinic wenziwe ba uhambe uyoma pha at the right of the queue as a form of a punishment. Xa usuka apha around e-Eastern Cape uyofuna umsebenzi eGauteng okanye eLimpopo ufumane pha uqala utreatment pha uphela umsebenzi kufuneke ugodukile xa ufika kwiclinic elapha into oqala uyifunayo yi-transfer letter kuthiwe go back to eLimpopo uyofuna a piece of paper that will save your life. Yet in the constitution of the country we've got section 27 of the constitution which protects the rights of the citizens of South Africa, those who work in South Africa, and those who stay in South Africa. And that section of the Constitution tells us that we've got a constitutional right to access quality healthcare services. But when we go to our clinics, our rights are violated. Not all nurses and all facilities are doing this, but one rotten potato in a bag of potato will mess the whole bag of potatoes to be rotten. The reason today we've got amanani amaninzi abantu abadefaulta kwi-treatment kwezinye zizizathu ezibangelwa zizinto ezenzeka kwi-clinic zethu. And if ezi zinto zenzeka kwi-clinic zethu azilungiseki, amanani abantu abadefaultayo ayanyuka. Ithethe ukuthi lonto leyo abantu abaninzi bazawukhetha ungayi eziclinic, bakhethe uzithengela amayeza pha kweza pharmacies zesetown. And then question izawuthi ke ngoku xa nabantu abaninzi bengayi eziclinic yintoni ireason ye-department iqeshe onesi abaninzi nogqirha abaninzi? Because abantu abayi pha. But also on the side of the department and those who are in authority, xa bezazi ezingxaki sikunye nazo singabahlali, benzani bona uzama ukulungisa ezingxaki? Asizange uzowulwa abahlali. Sizama udibanisa umhlali kunye nonesi kunye naye wonke umuntu onegalelo kwimeko zezempilo. Sibonisaneni ukuthi kwezi ngxaki sihlangabezana kunye nazo silungisa njani le meko kwenzela ba wonke umuntu xa ene appointment eclinic avuke enomdla abe eyazi ukuthi uya eclinic that is going to provide quality healthcare services. We've got a problem, comrades. Abanye abaphathi like lo usandosuswa nguPremier Oscar Mabuyane. Oscar Mabuyane did a very good thing by removing Roland Wagner as the HOD of health in Eastern Cape. Because Roland Wagner was not serving the people of Eastern Cape. She was only serving her pride. And as TAC and Ritshidze, we are fully behind the removal because we want officials who are going to respect the people and respect the constitutional rights of the people. Not officials or heads of department who will sit in comfort zones and not do anything about the problems that we are faced with on the ground. In Eastern Cape, we are the worst performing province when it comes to health. Yet she is sitting there with more than 1,000 posts of people that needs to be hired. She's sitting on top of that. We've got a problem of infrastructure. We've got problem of ambulances. We've got problems of many things. Yet I do not know how many meetings we convened with the MEC. MEC uyaza, Dr. Roland Wagner is not there. Our districts A2, we expect improvement. As the head of department, she was not doing anything about that. So we do not feel ashamed about that. We fully support Premier Oscar Mabuyane with the hope that the approach the Premier has taken to remove officials who are not performing is going to cascade to the level of the districts and health establishments because we want services. Banbaguti, the country is moving towards the NHI. And if South Africa is not doing well on our response to HIV, abantu abangayifuniyo i-NHI will take failures and mistakes ezenzeka ku-HIV and TB response and say, if you are underperforming here, how do you think you are going to implement the NHI? So, sizama ukulungisa ukuhlala. sizama ukulungisa imeko zethu, but not only kwezi facilities around up, kwi-facilities zonke esinazo eMzantsi Afrika. Ngaloo mazwi ndizama ukuthi ndiyanamkela abantu bakuthi. Bakho sizawunikezela ingxelo apha. Bakhona abahlali abanezitori that are recorded. Bakhona abahlali abakhoyo apha endlini. And then emveni koku xa sesigqibile sizawunikezela kwi-department ihlomle. I do not know whether zikhona i-district support partners ezikhoyo apha, but without wasting any time, bantu bakuthi sendiyenzile i-introduction and i-state of the nation. Benzama ukuthi kubantu bakuthi singabe navalo, singabe naxhala, sithetheni nje akuzange uzokliwa apha. Because we know ukuthi i-majority yethu abalapha asizanga nje basefuna balapha, silapha to share our stories and what we experienced kwi-clinic zethu, abanye bethu ezibangela into ukuthi singafeel comfortable to go back to our clinics. Without wasting any time, I will hand over to Comrade Usimpiwe to lead us on the following issues as I reflect also: staffing and waiting times, ART collection, ART continuity, key population services, index testing, infrastructure and clinic conditions, as well as TB control, TB infection control. Over to you, Comrade Simpiwe.
Thank you, GS. This week, we launched the 3rd edition of the State of Health Report for the Eastern Cape, developed using data from Ritshidze's community-led monitoring. Ritshidze monitoring takes place on a quarterly basis in 46 facilities across the province. This week, we have held 2 community meetings. Earlier this week in Buffalo City District, and today we are here in OR Tambo District. In today's meeting, we are deep diving into both the progress and challenges across OR Tambo District, where we monitor 14 facilities. We will hear directly from people living with HIV, people who use drugs, sex workers, LGBTQIA plus community members, and other public healthcare users as to their real experience using the clinics in the district. Data are collected through observations as well as interviews with healthcare users, which are public healthcare users, people living with HIV, and key populations, as well as healthcare providers who are facility managers and pharmacists. Data in this report were collected between July and August 2023. Interviews took place with 14 facility managers. Observations took place at 14 facilities. Interviews took place with 732 public healthcare users. 56% identified as people living with HIV, and 16% identified as young people under 25 years of age. Additional data were collected between July and September 2022 among communities of key populations. Interviews took place with 67 gay, bisexual, and other men who have sex with men, 86 people who use drugs, 21 sex workers, as well as 5 trans people. The first group of issues are on staffing and waiting times. Improving the state of health services provided at our clinics so that all people living with HIV and key populations can access friendly, welcoming, and quality services depends mainly on having enough qualified and committed staff in place. Yet, this year, only 40% of public healthcare users interviewed reported that there are always enough staff at the facility. While this has improved since last year, where 32% of people said there were always enough staff, 52% of people still thought there were never or only sometimes enough staff. From the perspective of facility staff, only 21% of facilities monitored reported that there were enough staff there were enough clinical and non-clinical staff to meet demand, just up from 19% last year. There's still a way to go to fill the human resource gap, as 79% of facilities monitored remain with too few staff to meet demand. Of facilities reporting shortages, 40% of facility managers blamed staff shortages on one or more unfilled vacancies, and 30% blamed staff being away on sick leave. According to facility managers, the most commonly understaffed cadres were professional nurses, enrolled nurses, pharmacist assistants, linkage officers, and data capturers. The number of vacancies in OR Tambo has reduced from 121 last year to 69 vacant positions now in the facilities we monitor. The highest number of vacancies by cadre are professional nurses, enrolled nurses, data capturers, and cleaners. 71% of facility managers we spoke to specifically wanted additional human resources for health support from the PEPFAR district support partner, which is TP HIV care in this district. However, PEPFAR's funding for critical HR posts has only reduced in recent years. The average waiting times have reduced by 45 minutes in the last year in facilities monitored in OR Tambo, down from 4 hours to an average of 3 hours, 15 minutes waiting in the facility, including time before the facility opens. And waiting times after the facility opens have reduced from 3 hours, 52 minutes last year to an average of 3 hours, 5 minutes waiting after the facility opens this year. Some facilities had waiting times over 3 hours, as outlined in the table, while with some waiting times over 4 or 5 hours. This means that some public healthcare users still spend hours in the facility, and this is a major source of dissatisfaction for those who experience the long waits. 57% of public healthcare users interviewed in the province think that the waiting times at the facility are long. This has worsened since last year, where 46% of public healthcare users thought the waiting times were long. 54% of public healthcare users blame long waiting times on staff not working, or staff working slowly. 26% blame staff shortages, and 37% blame filing systems that are messy or files being lost. While 96% of public healthcare users were aware of clinic appointment system, only 2% report getting both a date and a time, and 94% reporting just getting a date. This means people arrive early in a cluster in order to get seen, and clinics are empty by the afternoon. Appointments could be spaced out throughout the day to ease congestion. Filing systems were observed to be in a good condition in 14% of sites monitored, down from 33% last year, mostly due to filing systems being too small to maintain, and messy and disorganized filing systems increase delays and increase the burden on already overstretched healthcare workers. The average earliest arrival time has improved slightly from 7 a.m. last year to 9 a.m. this year. However, some people still begin queuing early in the morning in an attempt to get seen more quickly. 4 facilities monitored still have an average arrival time of before 6 a.m. in the morning. Of 222 people who arrived before the facility opened, 14% reported feeling unsafe or very unsafe while waiting for the facility to open, improving from 41% last year. While a circular was issued in May 2019 by the National Department of Health calling on facilities to open by 5 a.m. on weekdays, none of those monitored even opened before 7:30 a.m. Commonly, facility managers tell us that they are unable to extend opening hours due to insufficient staff to cover this time. We will now move along to recorded community stories.
Ndingumhlali eKhrizane. Thathela umama kasakwazi uhamba ipilisi eStanford. Siyafika pha. Sifika ngabo 6. Bona bastata ngo-8 kodwa basebenze 8:30. Silinde bathathe ifine zethu bazibhidanise. Siyotshona bekade bethathela abantu abadala bebodwa abantu abadala ngoba bebehlula abantu abadala ngoba sebebafaka bonke abantu abanabantwana. Basenze laa nto yabo and bagxotha abantu abarayithi babatshintshe kwenye ikliniki. Ifayini ziyalahleka bangapha vele kuthiwa ayaziwa enye imini. Phinde enye imini uphinde uboye uphinde ibone. Bakhona abantu baphaa cha ke ngoku abantu abasebenza phaa abanesi bavele ibe ngabo abaphumayo akho muntu olaphandle othatha ifayili abanike abanesi. Ngoku la bantu bathatha ifayini sengapha nangapha. Ipilisi ziyafumaneka zingafumaneki ezinye kube ekhemist.
Xa ndisiya ekliniki ndidla ngokuya ekuseni ngo-4 ndidla ngokuya ngolwezine manditsho. Ndiye ndifike abantu phaya ekliniki beyi-4 or beyi-3. Ndibalekela into uba emevana phaa evillage kliniki kuyagcwala. Ndifike ndihlale phaa phandle kuyanetha akunethi. Lifika ithuba loba masingene ngaphakathi. Siqale sithandaze. Sakuba sithandazile singeniswe ngaphakathi. Kungenjalo amanesi yonke imihla kungena imeeting evillage. Bayizogqiba emveni kwemeeting bangenisa abantu babo. Mna ndilikhehlekazi ndifike ngo-5.
Naso isikhalazo endinaso soba apha ekliniki emhlakule asihoyeki and mna ngokwam ndiye qale last year ubona kwam le ngxaki ndinayo oko ndisiya andifumani uncedo. Ndaphinde ndashifte ndahamba ndaye eMthatha naseMthatha kunjalo eNtaphane andifumani uncedo. So andiyazi uba ndizothini kanjani ke ngoku ngoba abantu balapha ekliniki abafuna ukusebenza vele. Nayizolo besihleli phaa imini yonke sibuye ngala maxesha phaa ngo-4 oko besihleli phaa. Akho nto siyenzayo akho nto ndiyifumanayo. Uncedo ndilidingayo mna kuko ngoba ndineentsumpa ngaphantsi so ndizama uba zisuke andiyazi uba ndingasusa njani ngaphandle uba ndingaya ekliniki. Like ngoku abona ndidla iipilisi i-ARVs kodwa ndaya ekliniki xa ndifika ekliniki xa ndiphinde uba nditsala amagazi ii-results azibuyi. Ifayili yam bathi ilahleke uba mandiphinde ndiqalele. Okwesithathu ndiqalele into yefayili. Kuthiwa mandiyijonge phaa kule ndawo zihlala kuyo mandihambe ndiyoyibuza kwabantu basefestileni. Xa ndifike ndibuze efestileni kuthiwe mandiphinde ndivule enye. Nabanye abantu ngoku abafana nabo basekhaya nalo mntana sekandimzekela umntana sibesihamba naye. Naye udinga into zomntwana adala siqoqe ekliniki still akafumani uncedo. Mna urhulumente ndingathanda uba angekasiphinde asikhalele abanye amanesi kalala apha hayi anqabile. Mhlawumbi ngatsho kube ngcono xa kukho amanye amanesi.
Ndiklinika eNtshele. So eyona nto ndiyikhalazelayo indiphatha kakubi yile yoba xa ndisiya eNtshele kuyanyanzeleka uba ndibe nayo imali nge-100 rand xa ndisiya phaa. If andinayo andikwazi uyofika because naxa ndinothi ndihamba ngenyawo funeke ndigqithe ithafa ngapha elide nditsibe ilali eziyi-2 ukuze ndiyofika and ke yirape yodwa leyo. Sewupha ekliniki eNtshele phayana mna ke xa ndiye phazi ube ndiyohlukuhla. First day ndingazazi uba into yam ithini. Ndandifuna uzazi mos uba isimo sam sithini. So ndathi xa ndifika phaa funeke mos uqala utheste. Xa ndifika phaa kwathiwa hayi sizithengele ngokwakho i-pregnancy test asinayo thina. Uze nayo intsha sikwenze ke ngoku okanye uzenze kowenu utshuzo osixelele bendithini. Ndaxa kuba yikliniki enjani le ingeza uba na pregnancy test. fine ndayiyeka leyo but ndayenza ekugqibeleni ndazazi uba okay ndimithi so kwaphinde kanyanzeleka uba ndihlukuhle phayana. Xa i-R100 ingenayo ndiye nditsibe ideyithi le bendiyibekele uba ze ndibuye ngayo. Once utsibe ideyithi yakho xa uphinda ubuya ngaloo mini uthe wama ngayo kakuhle uyifumaniseka uba kuthiwe oze ngedeyithi engeyo yakhe siyagqibela ngaye ube phofu ubuvuke phantsi usuka kude. Kodwa hayi siyagqibela ngaye sawuqala ngaba baneedeyithi zanamhlanje. So ke indiphathe kabuhlungu loo nto because endaweni yam akho kliniki. And ke ndibachazele loo nto uba mhlawumbi bendingenayo imali yokhwela funeka uze ndifika apha ndibe nemali okanye bekunetha ngemini ethile. Izawuthi ke umntu xa ekuphendula hayi mna sisandingendawo kuloo nto umsebenzi wam ngulo ndizowenza phaa kuwe uba wena waza xa kutheni awaza xa kutheni andingeni mna leyo into fanele uba wena sangale deyithi sikuxelele yona. Qonda uba indiphathe kabuhlungu ke ngoku loo nto because bendingenayo imali bendingazuyithatha phi futhi. If bekusithiwa sinayo ikliniki eyethu kweli cala bekuzawuba bhetele ngoba ke oonesi baphaa bavele ndibona uba banalaa nto xa ungengowaphaa usuthi usuka kude ubona uba inesi ivele ikuphendule kabuhlungu kakubi kugwexe for le nto iyazi uba ukusala uhlala kude konyanzeleka uzofika apha xa ufuna uncedo.
Ndiklinika phaa eGateway. Ingxaki yam ke phaa xa sifika phaya sifika abantu bebanintsi and ke phaya sivuka apha ekuseni ngaba-4 kuba suke sikhwele amateksi. Fika abantu bebanintsi sijonge into yoba ke sifole ilayini phaa. Agqiba ufole le layini umanise uba abantu njengoba siyongena ngaphakathi phaya ukuqala ukusebenza ke bawuqala ngoba ungabo-8. Ngoku loo nto ke ithatha ixesha ke ngoba ufumanisa into yoba oonesi aba basenza komabhalana banexesha bafuna baye ebreykini ndiyabona. Xa sifika phaa koogqirha sifika sesileyithi ngoba ngexesha ke kufune ifayili ayikho ifayili ndiyabona. Ngoku yonke loo nto ithatha ixesha elide njengoba ufuna uhlala 3 hours ubhalwe phaa ufuna uhlala 3 hours esiphaa ekliniki iba imini yonke loo mini yonke funeka uyigqithe phaya ndiyabona. Newuchithe phaya enatsikeni phaya uyazi ukuthi awukho enye into uzawuphinda uyenze. Cinga ube noba bayashota ngoba lokhu bona xa bayatsho nabathi asiyashota napha kwemfaxazweni sibambalwa ndiyabona. So ngoku kuyanyanzeleka sihambe le queue i-1 ubheka phaa kuye. Hayi siphatha kabuhlungu kakhulu ngoba lo singumuntu omdala uba mna sendingapha kwe-70 years yabona. Ngoku kuyanyanzeleka into yoba ngoku xa ndifika phaya ipressure seyiphezulu funeka ndinike amapilisi okuthoba ipressure ndime ecaleni phaya yabona. Ngoba loku ngoku ndiyacenga uba amateksi andishiya kandigoduka yabona. Abekho namakhaya abekho. Ikho enye inkqubo bakha bayinantsika bakha bayisebenzisa yokuthi siyothi alanda amapilisi kwa-clicks yafeyila ayiphumelele zange iphumelele.
We will proceed to community stories in the room today.
Ndisebenzisa iLusikisiki Village Clinic.
I use Lusukisiki Village Clinic.
Bendiyileke kule nyanga ndiyopreventa.
I went there this month to do my contraceptives.
Ndifikile phaa ilayini ibingendanga but oonesi bebengasebenzi besenza kancinci.
When I got there, the line wasn't that too long, but the nurses were a bit slow.
Mna ndisebenzisa idepo for ukupreventa but ngalaa mini ndafika ingekho. Inara indiphathi kakuhle ndiye ndiye kwi-periods more than iintsuku zam zokuya.
I normally use a depot for my prevention, but on that day it was not available, and Narastarity does not treat me well. I go on my period for a longer period of time.
Sometimes uyakwazi ukufika i-pregnancy test ingekho bakuye kuhlale elayinini bengakuxeleli uthi sowuphambili kube mnxeba zokuxelela uba i-pregnant test ayikho.
At times, you are requested to take a pregnancy test, but they will tell you that they are not available and they will not inform you while you are waiting in the line.
So kufuneka ugoduke ungapreventanga.
All in all, we go home without any prevention.
Xa uye wopreventa onesi baye bambile baye elantshini ixesha elide bathathe 3 hours mhlambe. So xa sebebuya babuya seberude benikhwazela uba sizonishiya apha thina vele ixesha lethu seliphelile ngoku nani nifike emini ekubeni bufike ekuseni.
Even for just going for prevention, the nurses do not pay any attention to us. Instead, they take their lunches, and when they come back shouting, saying that they cannot just stay without taking their lunches.
Ndisebenzisa iHoly Cross eFlagstaff.
I use Holy Cross Clinic at Flagstaff.
Into enzekayo noba ndina 2 years ndithatha i-treatment ARVs.
It's been 2 years I was taking ARV pills.
Into enzekayo xa nditsale ipilile xa nditsale amagazi xa sebebuyisa i-result abandichazile banika iphepha bafake ifayilini bangachazi uba amagazi am ame kanjani.
So when I go for my viral load test, they do not explain the results to me. They just take them and put them in my file, and they do not explain anything to me.
Ndisebenzisa iFlagstaff Clinic.
I use Flagstaff Clinic.
Ndithatha i-ARVs phaa iFlagstaff.
I take ARVs there.
Xa ndiye ndiyozithatha ndiye ndivukele ekuseni.
When I go there for my collection, I wake up very early in the morning.
Ndifika ndime elayinini phaa ihambe ke ilayini. Xa sendingenile ngaphakathi kuthiwe ifayili yam ayibonakali.
While waiting on the line and waiting for too long, when I get inside to go collect my file, they tell me that they don't see it.
Kuthiwe mandime ecaleni ifayili isazojongwa. Ndime ecaleni nge kodwa ndixhinile ndifuna ugoduka.
They will tell me to stand aside while they're still looking for my file.
Okanye xa sele kuzobetha O3 kuthiwe mandize ndibhalelwe ecaleni ifayili yam ingafunyanwanga ndinikwe amapilisi am ndigoduke.
And they will only pay attention to me after 3 hours or at 3. They will use a paper to write for my prescription so that I can get my pills, and I'll go home after that.
Ndisebenzisa i-village clinic.
I use village clinic.
Izikhalo sam zininzi kakhulu ngala village.
I have too many frustrations about the clinic.
Mandisuka endlini ndiphuma ngo-6. Nokonde kuba andikudanga kakhulu ndihambe ndiyofika e-village.
I wake up at 6 in the morning. The clinic is not that far from me. I walk there.
Hayi ke ndifike ke ndihlale phaa elayinini phandle.
We queue the line outside the clinic.
Awubetha ke u-8 kungekavula ngeli xesha bendifikile okanye ndifike phaa ngabo-7 ndifike ke ndihlale ke elayinini. Kufike amanesi nje nabamathathu kuthiwa hayi ke akukavulwa nje nihleli apha ke ngoku nawo ke nihlale ke nilinde uba akukavulwa.
They do not open before 8, and even if the nurses are there, they tell us that we will wait outside because they are not open yet.
Hayi ke bavule ke singene ngaphakathi sihlale.
And when they open, we wait inside.
Bathi phaa emva ko-8 kube manxa basiqalisayo ukusebenza kumbani sihlale ke kubethe naba ngu-11 sengaqaliswa kwakusetyenzwa kuthiwa asawulinda kude kubuye umbane.
So they only start work after 8, and they are being slow, and sometimes the electricity goes, and we have to wait because they do not work when there's load shedding.
Hayi ke kodwa kusobuya umbane sisetyenzwe kancinci ubona uba hey sowulambelwe kungakutshutshu ngokudla uba hey kudala ufike ekuseni apha bakusebenze ke uhambe uyofika uma uyofika kwifayili nje into evele ixakekise ngamandla ufika kwakho kwifayili ufumane kwafayili wenzelwe enye ubuye unye kwenye inyanga uthi hayi ke bhuti kakuhlale kancinci sisakhangela eyasizophinde siyibone le yakho.
They only start working after the load shedding comes back, and they are very slow. And even if you are trying to look for your file, sometimes they get lost, and they will tell you to wait for quite a long time so that they can keep on serving other people, and you will wait while they're serving other people, and yet you were there very early in the morning.
Hayi ke ndawuhlala ke ndisenzelwa le file ndizive ndisithi hey kodwa le ndlela nenza ngayo kule village yenu le clinic angathi izawundikhathalisa uba iya-7 kolena ifayile ndibuzana nento enye mpela ndizilapha ndawubhalisa mpela nindibuza into enye uba hayi ndithi ndibona babona ngosendizawuyeka nokusebenzisa la mapilisi ke ngoba yile fayile ndenzelwa enye ifayile ndenzelwa enye ziyi-7 iifayile zam eziphaa village clinic ndisenzelwa.
I usually complain to them each and every time I go there, telling them that this is the 7th file I'm opening with you guys, and you are not giving me any explanation. And as a result, I would just decide to leave or end up not taking the treatment at all.
Enye ndiyikhalazelayo ile yamagazi uvele nje unikwe elaphepha mawujonga apha kweli phepha awuchana okanye umcimbi uba hayi zeza ntoni ezingcele mawuzama ubuya kwenye inesi ubuza uba ithini into ukuthi hayi awubone na wena zezinye ke izinto ezizama sindikhalazise nenye futhi le yokuhlala pha phandle sinethwe zimvula pha ekliniki siyatshala ilanga siyanethwa zimvula pha kule village.
My other challenge is that when you take your viral load test, they do not explain anything to you. They just give you results. And even if you ask one of the nurses to explain the results to you, they just tell you that, or even ask that, can't you read, can't you know what is written on the results? And that frustrates me a lot because I don't understand anything. And one other thing is that we queue outside regardless of the weather there, and that too does not sit well with me.
Sicela ke abahlale ngaphambili abapha eklinika make bazama ukulungisa imeko zeefayili zethu madoda uba imeko zeefayili mawuyapha wenzela ifayili ngoku awusazazi naba ke ngoku uthini. Hayi ndiyacela enkosi.
I'm only asking that they have fixed their filing system so that we won't struggle on the filing system.
Thank you. So we sizawuya kuma recommendations. But before we go to our recommendations, I'm shocked uba ndive ukuthi even village clinic services zayo zipoor, because we fought for the village clinic as TAC and Section 27. When the Eastern Cape government didn't know what to do, we took the National Department of Health to court, and that village clinic is as the results of ETAC, ibamba urhulumente waseMzantsi Afrika bayakha. And when Aaron Motswaledi was building that clinic, Ute is one of the NHI pilot districts sites, that village clinic, and we expected Guti a village clinic is services is bengcono, but also the problem is around the missing files of the patients, because if a file of a patient is missing, it therefore means the medical record of that particular patient is also missing. And then the other problem that I am picking up from this meeting in Yoguti, as much as healthcare services, the public healthcare services are free, but for us, poor people, more especially abahlala with deep rural areas, they become too expensive because we have to use transport and that on its own, if on that particular day you went to a clinic and you didn't get services, it means you must come the other day and you must use money again. And I'm asking myself, what does free healthcare services means if we will be subjected to use a lot of money, not because of our own making, but because of the failures of the system? Now we are the ones who are on the receiving end. Our recommendations are as follows. The Eastern Cape Department of Health should produce an annual report on the number of healthcare workers per cadre employed in each district. Include the numbers of people and size of areas covered by these healthcare workers, year-on-year comparison from at least 2021, and the cost of these posts to the government. fill all vacancies in 2023-24 financial year. The Department of Health should extend facility opening times as per the 2019 National Department of Health Circular. Utilize appointment days and times to ease congestion. Ensure filing systems are maintained in an organized manner to reduce loss of files. Open clinic grounds by 5 a.m. so that people can wait safely in the mornings. Ensure files are not required for facility pickup points. For people living with HIV, go directly to the pickup points to collect their ART refill. Get more people living with HIV into external pickup points to reduce congestion in our facilities. PEPFAR should support in filling all vacancies at PEPFAR Operation Putuma support facilities in the short term. Provide additional staffing for all PEPFAR supported sites to extend opening hours from 5 a.m. to 7 p.m. on weekdays. Fund adequate numbers of adherence club facilitators to allow for the restart of adherence clubs. TB HIV care should immediately do an assessment at all PEPFAR Operation Putuma support sites with waiting time over 3 hours and develop a specific plan for each facility that will bring the waiting time below 2 hours. Support the facility to organize and maintain an organized filing system. Ensure files are not required for facility pickup points. People living with HIV go directly to pickup point to collect their ARV refill. Get more people living with HIV into external pickup points to reduce congestion. We will move to the next item now.
The next group of issues are on ARV collection. The revised 2023 National Adherence Guidelines note that time constraints are a challenge to many people living with HIV. They go on to say that efforts should be made to support people living with HIV with suppressed viral load to receive extended ARV refill or be enrolled in a repeat prescription collection strategy. Implementing this is vital to supporting improved long-term adherence. However, Ritshidze data reveals that only 26% of PLHIV interviewed reported getting 3 to 6 months ART refill this year in OR Tambo. While this is a marginal improvement compared to 22% getting 3 to 6 months refill last year, it is well below the 80% of people living with HIV in 21 other PEPFAR-supported countries reported to get 3 to 6 months ART refill in 2021, and below the number of people reporting 3 to 6 months refill in Buffalo City and Amatole. Of people living with HIV interviewed by Ritshidze, 44% collected at standard medicine dispensing, with 14% collecting at facility pickup points and 38% using an external pickup point. For those using standard medicine dispensing, 68% said they have not yet been offered the option to use the pickup point. All stable patients who are living with HIV should be offered a range of repeat prescription collection strategy options as per the National Adherence Guidelines. Further, 60% of all people living with HIV interviewed said that they would like to collect ARVs closer to their home if it were possible. There need to be enough pickup points to detain people into, especially linked to peri-urban and rural clinics. A diversity of external pickup points providers is needed beyond private pharmacy networks that are largely only available in urban areas. To service rural areas, small CBOs, and early childhood development centers should be considered. In terms of adherence clubs, these options have been devastated since the onset of COVID-19. Most clubs have been suspended or reduced to being just a pickup point. We maintain the fundamental adherence clubs plays an important role in supporting the ongoing treatment literacy and peer support to help people living with HIV to stay on treatment. Importantly, in order to be effective, repeat prescription collection strategy should make ARV collection quicker, easy, and more satisfactory for people living with HIV. Yet, this is too often not happening. While only 3 facilities monitors said that people using facility pickup points must collect files, take vitals, and see a clinician before getting their parcel. 40% of people living with HIV said that this is the case, adding to delays in the facility. While it should take less than 30 minutes to collect your parcel and go, 17% of people interviewed said it takes up to an hour, and 9% said it takes between an hour or more. Once enrolled, every effort should be made to keep people continually active. Reassessment should take place at each clinical consultation to understand if people living with HIV are satisfied using their pickup points or clubs. People living with HIV who are not satisfied or very satisfied, as reported by 17% of people using facility pickup points, should be offered different options that better meet their needs. We are now move to recorded stories.
Ndisebenzisa nditya ii-ARVs. Ii-ARVs zam ndizithatha engangelizwe clinic. Ndafumana ingxaki ngo-2022 engangelizwe clinic. Ndiyothatha i-treatment ndinee-dates zam. Dates ezo sasithe xa sicaciselwa uba ngabana une-dates unengxaki akunyanzelekanga uziyele wena in person eklinikhi, uyakwazi uthumela ikhadi lakho eli line-date ngoba uzudibana nagqirha, uzudibana nanesi, uya nje straight edispensary bakunike ipasela yakho. Ndayenza njalo ke, ndabe ndine-appointment ndizawuya komnye ugqirha ngaloo mini leyo, ndathumela manyanyana ikhadi lam ngomntu uba makahamba ayondithathela itreatment. Wabuya laa mntu ungandiphathelanga itreatment esithi kuthiwa itreatment yomntu ayithathwa ngomnye umntu. Anda-andastenda ke qha ke kuba ndandibhizi andakwazi uba mandiye ngoko nangoko eklinikhi. Inoba iklinikhi ndaya after 3 weeks time. Xa ndifika eklinikhi after 3 weeks time ndaxelelwa bambethela futhi nombethela istampu esiphruva into yoba ngalaa date ndiyile uyozithatha iipilisi, qha bamnika. Xa ndifika eklinikhi bathi bazawundihoya ekugqibeleni, ndabe apha ekhaya ndiphume ngo-6 ekuseni. Bathi bazawuqala bagqibe bonke abantu abayithatha ngendlela erayithi itreatment yabo, mna bazawundihoya kamva ngoba kaloku ndingudefaulter. Ndabuza ke mna ke ndingudefaulter kanjani kodwa bendimthumele umntu ngedate yam uba makazondithathela itreatment, nina nangamniki itreatment. Kodwa sisingathi unento eninzi noba ucinga fanuba uyinesi, khawubhekele khawuphume ngapha ecaleni. Ndaphuma ecaleni ndayibetha ndabuya ndagoduka ngoba lo ndandidiniwe ndilambile ngoba ndisuka apha eWaterfall ndithenga ngelizwe ngenyawo. Ndandidiniwe ndilambile ndicingela nabantwana bam bazawubuya esikolweni bangabi nakutya apha endlini. Ndavele ndaphuma eklinikhi ndabuya ndeze ekhaya and ndazixelela ke ngokuba andizophinde ndiye eklinikhi, ndizawuhlalela ekhaya. Manyanyani ndahlala ke ekhaya. Ndithe ndisesekhaya ndabanjwa zii-shingles ngoba kaloku itreatment andiyityi ngoku. Ndithi uze ndiyitye itreatment omhlawumbi ndidibane nomntu otya iipilisi ezifana nezi abe ndizitya, ndimcele xa ineepilisi ezi-extra ndithi ndicela ndiphi iipilisi, atsho andiphe ke manyanyani umntu nditsho ndisele. Athekwa zii-shingles ke ngoku and engangelizwe xa bekuxelela ingxaki yakho like laa nto yoba bendinika igama elitsha elithi default of which nandiyile nge-daytime clinic zange ndiyibhute daytime clinic abakuxelela uyi-1 bakuxelela kugcwele abantu phaa ingangelizwe ube ujongelwe eli gama lithi default ingathi mhlawumbi andizazi bezipilisi ndizityela impilo yam ingathi ndizityela impilo yabo le nto bade bandinika amagama oba ndingu-default yho indiphatha kabuhlungu kakhulu mna into yoba singahoywa ingangelizwe because eyona nto ingamandla abantu oonesi bethu especially kweli cala lethu lika-HIV and AIDS abasikhathalelanga basitritha ingathi singabantu aba u-HIV lo sinayo sammele ekhawuntarini samthenga kanti zange simthenge nathi u-HIV sivisa kabuhlungu into yoba sibe-HIV babona esa stigma sisemntwini o-HIV basasincamathisela nangokwapha kuthi basenza singabi nayo i-confidence yoyikliniki ngenxa ka-HIV wethu ngenxa yendlela abasitritha ngayo umzekelo mna binondonwabisa into yoba like le nto basenzela yona yoba basinike za date zethu uyayivala nto ndiyithethayo umntu xa eneza date zakhe kwaziwe into yoba apha eWaterfall mhlawumbi sinabantu abanga abathatha i-treatment yabo ngedate ethile sibizelwe ku-community hall yethu sihambe siyothatha i-treatment yethu ku-community hall yethu because omhlawumbi noba babethwa nayo laa nto yoba ikliniki kuya wonke umntu onesigulo ne then umntu aze neengxaki zakhe zakwakhe azosikhuphela apha kuthi nathi sibe sinezethu iingxaki and kaloku umzekelo xa u-HIV nawe uvele ube nomsindo umntu xa ekwenza uba mawube nomsindo yayiva uba ngaba bangake basenzela into yoba basizisele i-treatment yethu bangathi napha ikliniki xa besinika i-treatment yethu kucaba nina ni-HIV yiyani kwelaa cala lingaphaya nina nineswekile yiyani kwelaa cala lingaphaya ukwenzela uba wonke umntu azokwazi uba u-HIV uyabona mos bayasidisclosisa bona ngokwabo singadisclosanga thina on our own umzekelo engangelizwe kudala kwakukade kusithiwa abakadlamini ngapha bapositive ke wawusaziwa ngumntu wonke kwaloba kuthiwe ngokadlamini wawusaziwa uba upositive uthi noba sowusendaweni ke ngoku yolonwaba apha eWaterfall ukhonjwe kuthiwe yho nalo utya iipilisi uyayibona laa nto leyana
ndingumhlali waseKhrizani ndisebenzisa iklinikhi ekuthiwa kwamasipala Stanford xa ndifikile ndiqala ezijophini zam xa ndifikile ndiyocela ukubhalisa kuye kuthiwa ndilate akusabhaliswa phaa kubhaliswa khona ufike bevala ifowuni bevala ifestire becofa ifowuni xa usithi uyaphuma emnyango ufike bekuleqa uba ndathi mna ndiyofuna umphathi walapha kuba ndizocela i-treatment yam mna ndiya ARVs ekliniki ndiye ndiqala ejophini yam okanye ejophini ndiye ndingene ngo-6 ndiphume phaa ngo-9 ndicele phaa kusasisi ndimphangelelayo uba ndisale kuyothatha i-treatment yam ngoba zange ndiyifihle ndathi ndithi i-treatment ndihambe ndifike ndihlambe ndileqe ekliniki xa ndifike ekliniki ngo ndiye ndithi xa ndiyile khona ndingaphatheki kakuhle ndizibone intliziyo yam i-down ndingekho rayithi ikliniki yalapha eStanford ayinambeko iinesi ezisebenzayo phaa ziyabaleka noba ungathiwa masizivotele kavotele okanye ngaphuma ezi-2 okanye kuphume 1 ingxaki yakhona ayinasiphatho ukufana nezecurity zakhona nazo ziphendula ukuthanda kwazo xa zithanda wonke umntu uphuma ekhubekile phaa abantu abadala balambe bafele phaa indlala kuthiwe xa ndiyobhalisa ixesha ngeli xesha kubhaliswa ngoku mandihambe ndibuye ngakusasa kudala ixesha lindenzekelo ndithi sendile ekliniki kuyekwe phakathi kuvalwe ekliniki i-treatment ingayitholanga ndihamba ngemali ndiphethe ngenye imini okanye nemali yokukhwela kuphela ndibuye ngeenyawo ndikhathele ikliniki ivalwa ngo-5 ikliniki mna ndisuke ndiye ndifike okanye ngo-11 okanye ngo-12 ngezinye imini fike kungafunwa ukuba makubhaliswe kuthiwa yaye kukwenziwa loo nto yokuba makubhaliswe ngo-11 nango-12 bathi kwathi umphathi uba makungabhaliswa kusukela ngo-11 to kubetha o-2 no-3 babobhalisa boyekwa ngoku abantu bangabhalisi abantu abaninzi bajika phaa sebefikile umbone omnye uphathekile kodwa akazuhoya uzojika kuthiwa kwaye kubhaliswa ayinasiphatho qha ingxaki yakhona uthi xa sikhalaza sithi siyathetha sihleli phaa phandle silinde i-treatment kuthiwa siyathanda ukuthetha athi umntu ndizothatha iphesi yam mna andiqeshwanga nini ndigoduke ndiye kwam nam ndineengxaki zam indiphatha kwamna xa ndizovuka ndisiya ekliniki yaseStanford ndivuka ndanexhala ndilala ndizothukelana kuba ndiyaba ndivukele ndizobuya kulalwa andiphathi kakuhle bandithatha amagazi kuyi-1 unesi wandixelelayo wentsale apha izintso into enezintso phakathi waye wandibiza wandixelela uba ziyamfekshina kakuhle izintso zam. So ndihamba ekliniki eFlagstaff ndithatha amapilisi e-HIV. Ndithi xa ndisuke apha endlini ndisiya ekliniki ndithatha into engange-30 minutes. But ndithi xa ndifika ekliniki, let's say ndifike nge8:30 ndingene ndikale, kodwa kuyenzeka ndibuye ngo-3 emalanga. Kuye kuthiwe xa uhleli phaa ulinde iifayili zingakaphumi, kuthiwe hlala i-3 hours. So kule 3 hours ubone uba ku-more than the 3 hours. Uthi sawuyile ekliniki, umzekelo okanye ndiqwe idate, ndingayi ngale date ibisaphose uba ndiye ngayo ekliniki. Xa sele ndifika ngakusa ngengomso, bafike bathi mna ndizolandela emveni kwabantu ekuyidate yabo namhlanje. Let's say ndiye izolo kuyi-23, namhlanje yi-24, mna kuzothiwa ndizogqibela. Umzekelo ndizothatha amapilisi xa sebephuma. So ayindiphathi kakuhle loo nto. Enye into, bayalithatha igazi sisi, qha into endingayithandiyo yoba manditsale igazi ngexesha efana manditsale igazi kodwa ii-results zam bangandibonisi zingabuyi, zingabikho naphaa ngasemva kwifayili. And ndithi xa ndizibuza bandijongele ngelo xesha kwikhompyutha, kodwa mna andikwazi ukuzibonela ngokunokwam. Ndithi mna nam ndiyarhalela uba mandizibone efayilini yam, zibe lapha ngasemva, ndikwazi ukuzijongela ngokunokwam uba ndiyakwazi uzijonga. But ke ngoku njengoba bendiye ekliniki nge-19 banditsalile igazi, bathe ke ii-results bazozibuyisa kuba ndiye ndasifaka eso sikhalazo kubo. Hayi, andiphatheke kakuhle sisi kuba kudala ndiwathatha amapilisi bethi bazonditransfela efamasi, abanditransfeli. Ndide ndabuza ke bathi ke bazonditransfela xa sele ndibuya, uba bathe ndibuye nge-16 ekliniki. Bathi xa sele ndibuya ke ngoku bazonditransfela efamasi uba nabo kudala bebuza uba kutheni bekanditransfeli because kudala ndiwathatha amapilisi.
Ngumhlali, ndihlala eSlovo, ndisebenzisa uStanford Terrace Clinic. Kwa registration ihamba fast andifuni noxoka. But xa sekufikwa ke ngoku phaa emanesini, hayi athatha ixesha lawo kakhulu. At the same time ke ngoku thina njengoba sijongile njena, kwabona bafika noba kunini basiqale kade, then ufumanisa into yobana uzawuyeka yonke into ubuzawuyenza wena ufikela ukuze ekliniki kha bathatha ixesha, abasihoyi amanesi. Ooklark bona hayi ndiphuma nabo bahamba phambili. Last time ndafika nge-6:30, ndahamba u2 ebethile, wayesebethile u2. Nalapho andasiwa enesini kwavele kwathathwa njengento yobana HIV, yho ndandiqale uyithatha ngo-2015. Ewe kungcono ndiye ndilande eMedirite. eMedirite ufika anytime, ufike akukho netyhu, ufike uthathwe uhambe.
Ngumhlali wasePort St Johns.
I stay in Port St Johns.
Clinic yaseTombo.
I use Tombo Clinic.
Ingxaki esinayo thina phaya kula clinic yaseTombo into yobana usilinda ixesha elide noba ufike nini na eclinic.
My challenge with the Tombo Clinic is that we wait for too long regardless of the time you arrived at the clinic.
Sihlala phandle xa simfaxazayo, uqaphela uba uyomfaxaza ngabo-12 emaxesheni. Ufike phaa ufika i-pressure sekuthiwa iphezulu ngenxa yobana sitshala ilanga eTombo asinakwa.
We wait outside, and even the vitals, we take them outside, and you'd find that our blood pressure are even high because of the weather conditions outside.
Ndiqaphela ngedate ebendikhe ndaya ngayo nge-7 ka-August apho ndifike abahlali sele bekhalaza kodwa kwade kwapenika nami ndifike late ukuhlala silindile ekliniki, silinde umuntu ozokhupha ifayili ongaphumiyo ozosikhuphela ifayili.
I went there on the 7th and it was already late, but when I got there, there were already people that were complaining for waiting too long. And even myself, while arriving late, I had to complain because I waited for too long.
Alinakwa ixesha ekliniki elokunaka abantu, ixesha elinakiweyo lixesha lokutya.
They don't care about the time and the way the people are waiting outside. They only care about their teas and lunch.
silinda ixesha elide ingathi singancediswa kwixesha lokulinda ekliniki nobana xa sisiye ekliniki ingase iifayili zale date zihlale zi-arranged.
We would like more help on the waiting time at the clinic, and even the files, if they can retrieve them before time, so that we will not wait for too long at the clinic.
Enkosi.
Ndingumhlali ePort St John's.
I stay in Port St John's.
Ndihamba ikliniki eHealth Center.
I go to Port St John's Health Center.
Isikhalazo sam eHealth Center kufika ngexesha.
My issue at Health Center is arriving on time.
Uthi abe ufike ngolo xesha ngexesha uyophuma sekubetha o5.
And you notice that you leave the facility after 5.
Into eyenzekayo abantu xa kufanele yoba bahoye eHealth Center, inurses zihlala e-staff room xa kufanele zihoye abantu.
What happens there is that the nurses do not pay attention to the patients or the people outside. They only stay in their consulting rooms and not pay attention to the clients outside.
Into eyenzekayo bavele umuntu ahoye umuntu amaziyo. Ube kudala wena ufikile. Umuntu ofika ngo9. Umuntu ofika ngo9 ibe nguye umuntu ofumana uncedo wena ubufike ngo5. Uyahamba sekubetha o4.
They usually pay more attention to people that they know already and disregard those who were there earlier in the early hours. And you'll find that we wait and even wait for the people that come after 11 or 9 to get help before us.
Sesona sikhalazo sam eso ngoba singabantu beswekile thina ngabanye. Uye uphethe uzishiya uzopilisi ngendaba yokulamba.
That is my biggest issue, because some of us have other illnesses like diabetes, and you'll find that I end up leaving the facility without taking any treatment or receiving any services because of hunger.
Kangangoba kwinyanga ephelileyo bendilande ipilisi. Yathi into hayi ipilisi zam aziveli kwinantsika aziveli kwicomputer.
Even last month, I went there to collect my treatment, but when I got there, I found that my treatment was not there in the list in their computers.
Ndiye ndahlala ke ndabona yobana hayi mandinyamezele ngoba andinayo imali yophinda ndiye ekliniki.
So I had to stay because I didn't have the money to go back to the clinic.
Bayeke bandinika enye idate ndilinde lo date iki.
So they ended up giving me another date, not the treatment, so I'm still waiting for that date.
Enkosi.
Thank you.
Yeah, we have a problem, colleagues, and this problem, as mentioned by Abahlali, it needs an urgent intervention from the side of the department at all levels, because one of the reasons that makes many people to disengage or to be accused of disengaging is because the CCMDD program is not working very well. Because at times medicines arrive late or they don't even arrive to these pickup points. And we were promised by the Minister of Health that a policy has been passed and a circular has been shared with all provinces and districts on multi-month dispensing of medication. And we do not know, majority of districts and facilities are still giving people 1 month supply of medicines instead of giving people 3 to 6 months supply, because when people are given 3 to 6 months supply of medication, it therefore means you don't have to frequent the health establishment. You know that you only go there maybe 2 times or 4 times a year. But also, the other thing which I forgot to mention, colleagues from the department, I also serve in the office of the health standards compliance. I'm one of the board members there. And also the Office of the Health Ombudsman is under our office, where a lot of complaints are being reported on failures of the department. And in these reports, one of the things which is coming out clear is to say about 60% of the budget for health in South Africa, across all provinces, does not go to purchase healthcare services or products. It goes to medical legal claims. That's where huge chunk of the money goes to. Where abahlali are wrongly diagnosed or this or that, and then they end up going to lawyers. Lawyers will defend them, and the department will be found on the wrong side of the law. And I'm asking myself, what about these violations of human rights that are reported here? Because going to a health establishment and not get health services, it is the violation of my rights as a citizen in line with Section 27. To be made to stay more than 10 days without a treatment, that is the violation of my right. And if all these cases were to be taken to the courts of law, the department for sure was going to be found in breach of the constitutional rights of the people and end up paying. And I'm asking myself, as much as we are defending the rights of the people, but what does it mean when we have all these cases? It means if these people have to be compensated, the same money which is meant to purchase services, build hospitals, hire healthcare workers, is the same money that they are going to use to pay for these medical legal claims. And at the end of the day, services that are meant for the people remain not attended to. And I think it is important for us as the communities, civil society, to work together with our government and government officials in terms of trying to fix these problems. But also it will be a problem, colleagues, if it is only us as the users of healthcare services who wants to work with the officials of the government, and the officials of the government are not coming to the party, because we cannot keep on reporting about issues of staff attitude, stigma, discrimination, poor healthcare services, long waiting hours, and nothing is being done about that. Something must be done. Something must be done at some point, because I said in another meeting in East London 2 days back that I am tired of these meetings where I keep on hearing the same thing and there is no improvement. There will be a time where as TAC we will be left with no choice but sibuyele kwaNdalashi and speak the language our officials understands better. Not long ago, colleagues, in March this year, there was a big strike of healthcare workers unions, where imibutho yonesi nogqirha nabanye abasebenza phana bebetoyitoya befuna i-increase on salaries, befuna i-increase on i-subsidy for medical aid. And I was like, okay, as part of the working class, I understand the salary increase, better living wage, but I could not understand our government employees who are providing services with public healthcare system. They are fighting for increase for medical aid. It therefore means they are giving us services, bona, which they are not prepared to utilize them. They mess up our public healthcare system, knowing it very well. Private hospitals, they've got appointments. From 10 to 12, they will be there, they will be served. Go back to our facilities and they mess up with our lives. When they were striking for an increase, all clinics across the country were closed down. They were burning tires, chasing those who volunteered to come and serve. And none of those in authority suffered. It is us, the communities, who never received services. It is us, the communities, who experienced interruption of healthcare services. I said to TAC members in East London and across the country, next time, when there is a healthcare workers union strike and services are interrupted, TAC members and branches must organize taxis and buses. Take those people in our clinics. We send them to the nearest private hospital. We occupy private hospitals. We demand what was promised to us in 1996 in the Constitution, Section 27. Section 27 of the Constitution does not talk about private or public healthcare services. It talks about access to healthcare services for all. If they decide to disrupt services within the public health sector, let's go and occupy private healthcare sector. So that they can feel what we go through. Because we cannot be talking about our rights every time and again, but nobody cares to fix the problems that we're talking about. As I said earlier on, we are not saying all hospitals, clinics, and healthcare workers are the same, but there are those that are like rotten potatoes, and if they are not dealt with, it is going to be a problem. That's why even on my opening statement, I said, congratulations to, we support Premier Oscar Mabuyan for removing Roland Wagner as the head of Department of Eastern Cape, because she dismally failed the people of Eastern Cape. And we would like to see the same happening at all levels, where those rotten potatoes who are messing up the healthcare system of our country being removed, so that the people of our country can realize what was promised to them in the Constitution. Our recommendations are as follows, comrades. The Department of Health should extend and implement the ARV refills of 3 months by end of December 2023 and 6 months by end of September 2024. The Department of Health and TB HIV care should ensure all people living with HIV are offered a range of pickup point options, and those enrolled in pickup points or clubs are active. Ensure that reassessment of pickup point options take place at each clinical consultation to ensure people living with HIV remain satisfied with their pickup points or club. Ensure all facilities implement the 2023 adherence guidelines, standard operating procedures with fidelity, including ensuring facility pickup points are a one-stop, very quick ART collection, only visit under 30 minutes. No need to go to the registry, collect folders, see clinicians, and etc. Ensuring re-establishment or implementation of quality adherence clubs, including group facilitation component. Increasing the number and type of external pickup points to ensure urban, peri-urban, and rural clinics have external pickup points. Ensuring people going to pickup point or going back to clinic for their pickup point rescripts receive the rescript on the same day if clinically well, to ensure no unnecessary additional facility visits, with effect recall system to action any abnormal result or elevated viral load. PEPFAR should monitor and hold accountable PEPFAR district support partners to implement 2023 adherence guidelines, standard operating procedures with fidelity. We're going to the next item.
Thank you, Chair. Okay, we proceed to the next group of issues, which are on art continuity. People living with HIV lead complicated lives and may as well miss appointments and even miss taking some pills. When they do, meeting them with support when they return to the clinic helps ensure long-term adherence. But often, when people living with HIV and key populations return to the clinic, they are treated badly, leading to people disengaging from care. A differentiated service approach is required for people living with HIV who re-engage in care. Some will require intensive clinical management, including advanced HIV screening and management. Some will require psychosocial support in the form of quality counseling and group support options. The majority needed be made easier to collect treatment. These people should be offered multi-month dispensing and should be assessed and offered access to pick-up points or adherence clubs as quickly as possible. Implementing 2023 re-engagement, clinical and adherence guidelines are vital to supporting improved long-term adherence and retention. TB HIV care should support the remaining 36% of facilities and all others in the district in training and mentoring on the changes in the new 2023 adherence SOPs. Ritshidze data reveals that out of 732 respondents, 69% of people thought that the staff were always friendly and professional. This graph shows data across time since data collection began in the district. The district should continue to improve to ensure all people living with HIV, key populations, and other public healthcare users are treated with dignity, respect, and compassion at all times. It is also important to note that because Ritshidze interviews take place at the facility, people who have already disengaged from care due to poor staff attitudes, some of which we heard from community stories today, would not be at the facility to interview. Out of 65 people living with HIV who had missed appointments, 52% said that staff were welcoming when they came to collect ARVs if they had previously missed a visit, and 26% said that staff counseled them on adherence. However, 26% said that staff still send you to the back of the queue the next time you come in. Yet, according to the National Art Guidelines and Differentiated Model of Care SOPs, people should not be sent back to the queue or made to wait until the end of the day to be seen. A returning patient should take up the next queue space, and the guidelines specifically state that no punitive actions are allowed. People should join the queue as normal on arrival at the facility, irrespective of whether on time or late for their appointment. Punitive actions lead to people deciding not to come back again. We need to normalize late and missed appointments without penalty. People who have come back despite being late have made it easier for the health system. It is not necessary to track and trace them and encourage them back into care. The person has stepped back into the facility, so that experience should be as supportive as possible. While most people did not report transfer letters being a challenge, 101 people interviewed by Ritshidze had been denied access to services for not having a transfer letter across 9 facilities over the last year. While this represents just 3% of all public healthcare users interviewed in the district, given that most people interviewed are unlikely to have attempted to transfer services, it continues to point to a much larger problem regarding the communication and policies regarding transfer letters. A reminder that transfer letters are not required in the guiding principles of the re-engagement SOP, which states, if a person comes from a different facility, it is critical that the patient be provided with treatment on the day of presentation. While referral letters are helpful, a patient cannot be required to leave the facility without treatment. Psychosocial support is another critical element to ensure long-term retention. Positively, Ritshidze data shows that 91% of people living with HIV interviewed do know that psychosocial support is available. However, a full package of psychosocial services are not yet available at every facility. A full package of services should include provision of individualized, quality assured counseling to patients, peer-led patient navigators acting as a bridge between clinicians and patients, mapped networks or referral services, optional support groups, and food parcels. As part of psychosocial support, support groups should also be linked to each public health facility that are critical to provide counseling and support services to people prior to testing, post-testing, pre-treatment, and those struggling on treatment or re-engaging in care after a treatment interruption. Treatment literacy also improves ART continuity as people understand the importance of starting and remaining on treatment effectively. Of the 408 people living with HIV surveyed, 97% had received a viral load test in the past year, yet only 66% reported that they knew their viral load. Only 83% agreed with the statement. Having an undetectable viral load means the treatment is working well, and only 79% agreed with the statement. Having an undetectable viral load means a person cannot transmit HIV. There remains a gap in knowledge and treatment literacy. We will move along to recorded community stories.
Abezovala nabo. Qale sihlale waiting room. Silinde ukuyobhalisa iyaphela 4 hours sihleli pha singekabhalisi. Ngena sesibhalisile singena siyobona unesi. Unesi ofike ecofa ifoni yakhe engahoyanga. Kodwa sengingenile ngaphakathi. Xa ndangenile xa ndifika pha wafika unesi ichomi yakhe caba unesi bathetha nge-personal staff sabo bebodwa. So mna ndandihleli kwathiwa hayi bantombazana umamele ntoni. So bandishawuta because bathi mandingamameli iindaba zabo and all that stuff. Okay, fake kwangabikho nto wandinceda ndaphuma. Bane-attitude ezi-wrong towards abantu abafuna uncedo kubo. Mhlawumbi because hayi abakwazi ukuphatha abantu. Abakwazi. Uba benemali benze noba kuse-Holy Cross kanye ngapha kwabhala. Ndiphume kule ilapha e-Staff Clinic. Abanye babo baqhutyelwa boonesi. Khona omnye itshomi yam naye naye owaye-HIV positive and then akaziqalisa iipilisi zakhe ne just because washawutwa endaweni yokuba am-advise waske yena wathi hayi nguwe masowuvula imilenze tontoni endaweni yobathi hayi akokuphela kobomi wancama wangagqibi kwathiwa makabuye ke ngoku ezotsala amagazi and other stuff azoqalisa incwadi yakhe ifayili yakhe zangaphindeza.
Ndithatha i-treatment e-Holy Cross Gateway. Ndandiqwe ideyithi ndingahoyanga bayithini into neqwa ideyithi. Amapilisi am ndawaziselwa ngumfana ophangela phaa e-Holy Cross ungwalapha elalini ngumeza wam. Ndaqikelela kwi-treatment iphelile ndahamba ndalanda i-treatment. Xa ndifika phaa kwathiwa ifayili yam ayibonwa ndanikwa ikhadi lam. Kwathiwa mandiyobheka ifayili ndiyozikhangelela mna ngokwam. Ndahamba ndayikhangela kwathiwa ayibonwa apho bendiyikhangela khona. Xa ndibuya kwathiwa mandilinde ndahlaliswa phaa ezitulweni. Ndahlala into engange-hour ndilindile. Xa ndiphinda futhi ndiyobuza uba ikabuyini ifayili yam kwathiwa hayi ikabonwa. Xa sele iboniwe kwavela intombazana emnyango ethi Diko ibiza ifani yam. Ndaphakama ndahamba ndayomamela. Xa ndifika emanesini yakhona le indihlukumezayo inesi ethi kudala sikhwaza. Ndabe ndingevanga umntu okhwaza igama lam. Kudala sikhwaza wabetshawutisa lo nesi kudala sikhwaza Diko ufuna ukuthiwani umwakho. Ndamxelela ndithi bendingevanga umntu okhwaza uthi kudala sikhwaza. Kwayifayili yakho seyibeke ecaleni ndathi sister ndikuvanga naxa ukhwaza igama lam. Wabesithi yena kudala sikhwaza. Ndahlala phantsi ke ndalindela loo fayili bandinikeza. Ndaba ngumuntu ohlukumezekileyo ngaloo mini kakhulu kuba kaloku uphikisana nam uthi kudala endikhwaza ndabe ndiqonda uba mna andiyivanga kwayiloo nto. Bandinika ke amapilisi am ndabuya nawo. etshawutisa engathetheli le nto uba makuve mna naye ekhwazela le nto uba mandibuke babantu bonke abalanda amapilisi. Imphethe kakubi kakhulu kuba ke kunyanzelekile uba mandibe ndiyayitya i-treatment ndizawuya ndiwalanda amapilisi.
Ndiyipatient yase-Flagstaff e-Eastern Cape. Bendithatha i-treatment yam ndisebenza emarkethi, ndihlala emarkethi ngokomsebenzi. So emarkethi kwacaba uba ndiyeke umsebenzi ngendlela endingayiqondanga, ndingakhange ndithathe i-transfer, ndingenzanga niksi. Ndafowunela umsebenzi kwathiwa umsebenzi uphelile, ndahlala ke apha ekhaya ke yaphela inyanga. Uthe xa uphela inyanga ndathumela umntwana, ndathi makaye ekliniki. Uthe kunye ndiloko ndithumela umntwana wayekade esebenza khona le. Kuthe emva kwe-3 months umntwana wabuya wandixelela uba kuthiwa mandizizele ke ngoku. Hayi, ndathi mna ndacela inamba yakhona phaya ekliniki, ndathi ndicela nindinike tana iipilisi because andinayo imali yokuza apho. Wathi lo bhuti, umntu wayengubhuti, wathi yiza ifayili yakho asiyiboni, zozikhangelela ifayili yakho asiyiboni.
Ne-health center apha eLantoze ePort St George. Ndiye ndifike phaa ngabo-7 ndifole kodwa uncedo ndilufumana sekubetha oma-1:30 kodwa bendifike at 7:30 ekuseni. Into endiye ndayifumana ke ndiye ndafumana ikhe into engekhoyo phaya. Ndibe ndiye phaya ngokulanda i-medication yam ye-ARVs. I-ARVs ndinesifo sonantsika sokuwa. Into eye indibethe ePL Center yikheyo yamanesi angahoyiyo. Uthi noba ubuvukele enatsikeni cabe yobana uzothi uwe uquleke kukulamba. Ndiyawatsala amagazi eHealth Center, ndiwatsaleka kabini kulona unyaka. Andikafumani result ezithi hayi into yakho isahamba ngendlela. Ndiye ndithi kana ndicela yobana ndive yobana i-result ndicela ukuzibona. Bathi sizake sikujonge kwifayili yakho sizake sijonge kwifayili yakho ku-endaphe kulahleke naloo fayili phaya enye into eye iphinde isokolise phaya. Ndiye ndisokoliswe yifayili njengangoko yobana ifayili endiye ndaphinda ndayiqalela yifayili entsha. Leya ibineenatsika zam, ibineenkcukacha zam zokugula ekuqaleni. Zange ndiyithola until now. Ndaqalela ke ngokukwenza brand new file. Mna yonke le nto ngokwendlela engakhona yiyona endiye ndibone yobana indihlukumeza kakhulu apha entliziyweni yam, ngoba ndisuke ndithi ndilanda into ezawuncedisana nempilo yam. Kulapho ndiye ndifumaniseke yobana kungona indongezelela ukugula more, ngoba ndiye ndiqhutywe kungakwazi yoba ndincedeke.
Ndithatha i-treatment ye-HIV. Bendike ndayifumana eye-TB kuqala, yaze i-TB kwathiwa iphelile, ndafumana ke ngole HIV. Yile ke ngoku ndisebenzisa yona. Ndatshintsha ndabheka kwisistele yam eseManfle ndizoyithathwayo ngenxa yempilo, kuba ndindodwa ekhaya ndingenamntu okundihoya ondiphekela xa ndigula. Ndawuhlala kwisistele yam eManfle, kwiklinikhi yaseManfle. Ngoku ke ndibuyile eklinikini yaQumbu. Ngoku na apha uQumbu ke ngokuna ndiye ndafika ileta, kwacaba kufunwa ileta yaseManfle. Ileta yaseManfle ayikezi. Ngoku ndisalindile ileta ezosuka eManfle, kuthiwe izawuphinde ize nesisteli yam makulindwe. I-treatment yona baye bandinika i-treatment, bathi ke ngobalinde ileta. Ngoku na ideyithi yoba ndibheke eklinikhi andiyi eklinikhi ngedeyithi, ngoba kaloku andinamali yokukhwela i-R30 yobheka eklinikhi. Xa ndibhide ideyithi baye bathethe nje ukundingxolisa uba irongo le nto ndiyenzayo. Ndibe ndizibona nam uba ndiye ndirongo, ndirongo nje andizazi uba ndizokwenza ngoliphi uhlobo ngoba loko asikwazi ukuhamba ngeenyawo ikude ndelikliniki iwesi mna ndingaphilanga akukwazeki.
Okay.
Kuba ndiyazi uba ndizofike ndithethiswe phayana abazukuyamkela kakuhle kakuhle laa nto uba mna nje uba ndingayi phaa ekliniki ndibhude ideyithi andinamali.
Ndiklinika eGateway. Xa ndifika phaa eGateway ndisuka phaa ngo-4 uleqe ityhu eGateway. Xa ndifika ityhu inde sihlale ngaphandle into engange-3 hours for 4 hours bayovula nge-8:30 bona phaa eGateway. Ufika kwethu phaa siya estampini kuthiwa masiqale estampini yilayini naleyo. Sibithiwe masiye siyomfaxaza yilayini naleyo emfaxazweni. Siphume emfaxazweni siyolinda ugqirha. Ugqirha sifika engekabikho kwayena kwaphaa eGateway. Sifike phaa silinda ugqirha. Ugqirha uyawufika mhlawumbi ngo-2 okanye ngo-1. Ufika kwakhe akakhawulezisi naye xa engenisa umntu ungenisa umntu ahlala i-hour laa mntu. Mhlawumbi thina besifike ngo-6 siyophuma ngo-4 emalanga. And khandixelelwe into andazi into uba kwenzeka ntoni apha ebomini bam but ndihamba ikliniki ndihamba nje for the sake of impilo yam ngoba khandixelelwe into kwelaa gazi uba njengoba benditsala igazi kubonakala into ethile nethile. Ukucaciselwa noba yabona njengoba sikunika lena ipilisi sikunikela uba igazi lakho lithe lathi hayi akho kwanto unikwa iipilisi nje uhobe wepilisi ozawufika umtye umane kuthiwa qha itye ekuseni itye ebusuku nawe uthatha ezo instruction ngoba ufuna uphila. Banaxesha elininzi basixela uba niyadifolta ntontontoni kangamba sakhe sanombuzo wathi njengoba nithi xa singesi uzothatha itreatment siyadifolta xa kuthiwa masibuye ngomso sibe singenayo itreatment ngalo mzuzu asidifolti. Uphinde uthi xa uadyuwisha uphendulana nenesi ubone uba ine-attitude ngakuwe xa usowuphinde ubuye akakuhoyi okuya kokuqala uba ungumntu osileyo akafuni uthethe le nto iyinyani kuye. Rhalela uba ibe khona intsebenziswano phakathi kwethu nenesi bakwazi usi-understanda nathi sikwazi uba-understanda. Ithi into izihambe kakuhle si-understandana apha ebomini.
Two stories, community stories in the room today.
Ndiklinika kwaNtshele.
I use Njele Clinic.
Ingxaki phayana ndiyela omnye umntwana owayo wasiwa kumakhulu wakhe ena 3 months so wakhulela kuye wade wana 14 years.
I go there on behalf of a minor who is growing up with his grandmother who is 14 years now.
Lo mntana utya i-ARVs but akanayo kwanto senzisitsho akananto ezinjengebirth kudala ndizama ndibuza napha kwaNtshele uba abanokwazi na ukundincedisa.
He is taking ARV treatment but he doesn't have any documents like his identity card, and I've been asking at Njele Clinic for help.
Umakhulu la mntana mdala akakwazi uhamba. Unengxaki zakhe so la mntana if andiyanga akakwazi ukuyifumana i-treatment so xa ndiphinde ndisiya kwaNtshele bandibeka ekugqibeleni eyona nto yenza uba ndingafuni uphinda ndiye.
The grandmother is too old, she can't even walk, and the reason why I go to Njele is on behalf of the child, and if I'm not available on that date, the child does not receive his treatment and they don't give any assistance at Njele Clinic.
Into endiqapheleyo kwaNtshele if njengoba sihamba umgama omde I think sidlula iilali ezintathu uze ufike phayana.
We walk for a long distance to reach Njele Clinic, I think for about 3 villages to go there.
Ufika kuthiwe kuyabhaliswa ucinga uba xa ufikayo ube ngunumber 10.
When they do their registration and you find that you are number 10 on the list.
Kanti xa usele ungena ngaphakathi ungunumber 50 ngenxa ye-community yaphayana ayifoli yona iregistarisha ngefowuni akhwazwe eseza egeyithini okanye afowunelwe nihlale imini yonke.
you find that as you are number 10 on the list outside, when you reach inside, you are number 50 because of the members of the community. They don't do physical queuing. They do their appointments over the phone, and when they reach the clinic, they are called first before us, and we wait outside.
So phaa kukho usisi osebenza phaa as a cleaner. Uvele kuba abantu baphayana ebabona athi uyambona uyagula eseza phayana kodwa ngumuntu ubonwa siba uright laa mntu qha kuba eyitshomi yakhe okanye engwaphayana. Uba niyagula nina ninomntu oserious esitulweni kangoba kwenye igame kwade kwaxhuzula omnye esitulweni kudala semripota into enayo kuba wayengengowaphayana zange sihoywe.
This is usually done by their cleaner who's from the same area as Jele Clinic, and she would call people coming from the gate telling us that that person is too sick, so we have to give him way. But when we look at the person, we find that the person is okay. And one time we had a person who was very sick in the queue, she was having fits, and he did not receive any assistance because he was not from the same area.
Ndade ndabuza phayana uba ingaba oonomakhaya abe I think balapha ko-10 nangaphezulu umsebenzi wabo yintoni kwathiwa mandizibuzele phaa kubo.
I even have to ask about the healthcare, community healthcare workers, about their job because seemingly they don't do their job, and I was told to ask the healthcare workers themselves.
Ndibuzile uba njengoba ndizisela laa mntana kwakusithiwa ekliniki zibakhona ii-food parcels angaba abangeke bamnikene bathi urhulumente uyazithetha izinto awugqiba angenzi.
I even asked about psychosocial support with regards to food parcels because of seeing the situation for the child, and their response was the government says things and they do not respond or they do not do anything.
Cela ukuncedwa kulo mntana ngoba nam ngoku sendirhalela uvele ndibeke phantsi.
I'm asking for help with regards to the child as I'm seeing myself, I'm getting tired also.
Ndisebenzisa ikliniki yaseFlagstaff.
I use Flagstaff Clinic.
Ndaya ekliniki kungazo date zami sezidlule.
I missed my appointment date and I went to the clinic after missing my appointment date.
Ndandishawuta phambi kwabantu babeze ekliniki into yoba hayi wena uzawugqibela uzoma phaa ecaleni kude ugqitywe abantu uyidate yabo.
I was shouted in front of other patients and I was told to go back to the back of the queue.
Kwade kwafika ixesha loba mandingene ngaphakathi ndangena phaa emva kwa-2.
I got inside to the consulting room after 2.
Xa ndifika phaa reception ndicele ifayili yam kwathiwa ifayili ayibonwa yakhangela kwade kwathiwa mandizozijongela nam uba bayiboni.
When I reached the reception, they told me that my file is missing and I can even come and look for myself.
Ndayijonga ifayili ndithathe nezinye iifiles kuthiwa sisi uzawuziphinda uziphindise ngale ndlela bezibekwe ngayo kwezi files emva kokufumene ifayili yakho.
While I was looking for my file, I was told that I need to rearrange the file bags to the same way they were.
Ndagqiba ke ndazama ukuzipakisha ndizazi noba zipakishwa kanjani aloku andisebenzi phaa ekliniki mna.
I tried repacking them because I don't know how they are packed as I don't work there.
Ndasetyenzwa phaya yho i-attitude ababenayo angathi kwamna ndinuka le HIV.
While I was in the consulting room, I received a bad attitude because of being HIV positive.
Ndasetyenzwa ndagqiba ndahamba ke inkosi.
And sebenzisa i-village clinic.
I use village clinic.
Ndingumuntu onezito ezininzi onebhadile ucela iservice ebhedayo phaa eklinikhi.
I have too many challenges in that clinic and I am so unfortunate that I always receive bad treatment at the facility.
But enza usitsho esinye esandiphatha ndakhe ndilahlekelwa yikhadi lam.
My main issue there is that I once lost a file.
So ndaye ndofuna ikhadi phaa u-receptionist.
I went to the receptionist looking for my file.
And xa ndifika phaa kuloo sisi lo one-two nje out of the blue.
And the lady that was there just kept on insulting me.
Then wandibuza i-status sam.
And she asked about my status.
Xa sendimxelela i-status sam wendikhwazela wathi nazo into zengculaza ezi bonke ba.
When I told her about my status, she started shouting, saying you people are HIV positive.
Then waqhubeka ngithuka more than like 4 minutes, 3 minutes.
And she kept on insulting me for more than 4 minutes.
Then kwafika omnye usisi ozonginceda.
And one other lady came for assistance.
After nginceda ndalichola ikhadi lam, then ndamka ndathatha amayeza wam.
After getting assistance from another person, I went for my medicine at the dispensary.
Then loo nto yandenza ndangabuyeli clinic for more than 2 months after ndinocholile amayeza wam.
And that resulted in me disengaging from care for 2 months.
But ke ifamily yami yathetha nami yathi bandiphinde.
And my family had to talk to me so that I can go back to care.
Then ndaphinda after loo 2 months leyo. But ngebhadi xa ndifika phaa ndaphinda ndachola ndanikwa amayeza arongo.
When I got there after 2 months, unfortunately, I received the wrong medication.
Yeah, nazo izitori ndibulela.
Thank you.
Thank you. We will be going to recommendations now. You know, Bahlal, into emnandi sinabomama from good department up. And one thing that I know, at least bakwi positions up, ezinye zezi stories zethu ndababona mama bathatha phansi notes. And I'm sure after this, they will meet and maybe come up with strategies about how some of the problems that are reported here, they are intending to attend to them. You know, since Monday and until today, I have been following what is happening in New York. In New York, world leaders are meeting with United Nations General Assembly. And among other things, or the main thing about Tetanga the Sustainable Development Goals is 17, which all presidents of the country, there are more than 170 countries. And these Sustainable Development Goals, in the main, they talk about the rights of the healthcare users. They talk about the rights of the people in general, including the rights of the gays, lesbians, and everyone. And I was listening to them making commitments, including our president, making commitments on how they are going to deliver on the universal health coverage and making sure that the rights of the people are protected, which was something good. But I was asking myself, how many officials that we have in our government departments who are willing and prepared to deliver on that political mandate? Because on a number of occasions, we often blame politicians for taking decisions which are not implemented on the ground. And I'm asking myself, who is implementing these decisions? Is it politicians or officials? And when are we going to point fingers to the officials? But also, when I was having a meeting in East London, before that meeting, it came to my attention that Nelson Mandela Metro, Buffalo City, nase OR Tambo, there are facilities which are clear on Fridays, people are not getting treatment. And I had a meeting with Dr. Mowerani, the acting Director General of Health. We need to address this, including this issue of transfer letters, because we were promised that all people who are on ART have been enrolled on tier.net. And I was asking him yesterday morning, DDG, tell me, is this tier.net working or not? Because if it is working, why it is not utilized so that when people are moving from one area to another, all what is happening with facility, they just punch the name of that person and the ID number, the whole information of the person comes out instead of frustrating people. But we agreed, we are going to have a meeting so that at the National Department of Health, they can be able to write down these things. Nalendo yoguti umdu when they have missed the appointment, they are made to stand at the back of the queue. We agreed, not Dr. Morane, ukuthi this is not a standard operating procedure of the department, but this is what facilities decides to do. So we agreed that soon they are going to issue a circular to all facilities. Because as public healthcare user myself, ndiyayazi ba clinic uqala ngo-8 yoshopha ngo-1 to 1:30 kugcwele. But after 2 o'clock akusagcwalanga ezi clinics. So why ababantu who are missing their appointment dates, we don't take a decision. Instead of them waking up early in the morning, they rather come to the facility after 2, come and collect their medication and go. So that's why I'm trying to say we want to work together, and we've got suggestions on how healthcare services can be improved for the betterment of our people. Kubekho lo mcimbi kasisi lo belapha apho bethetha khona ngomntana ongena birth certificate, and she is forced to go and collect a treatment. I hope I department nathi sonke apha we will reach out to sis sibone ukuthi simnceda njani, because soon I'm asking myself ukuthi ingaba lamntana uyafunda na, and if akanayo i-ID, how is that mntana going to be able to write matric? And xa sesemkhulu ingxaki ingaba nkulu. Sinabo o social development, sinabo o home affairs, but I think even izikolo esafunda kuso and other people, I mean, I know ukuthi abantwana abangenabazali bayakwazi uadopt, and senza njani uncetsana kunye nomama in order ukuthi sebenokwazi unakekela impilo yalamntana kunye nekamva lakhe, because if alinaka kwelanga lamntana uzaphela ebasisigila mkhuba. And then the other problem, the other problem esinayo bomama, ngaba bantu baqeshwe eziklinik zethu, o-clerk, i-cleaners ne-security, hey, sometimes bazenza abantu be-department onesi, and basifaka involved kwizinto engekho suppose ba-involved kuzo. And kwezinye i-facilities you realize ukuthi they even collect patient files and distribute medication, and we always ask ourselves, where is confidentiality? When is security or cleaner bezayazi halwang anele yawo unengculaza, and then pa elokishini xa sixabana athi ayisuka hamba nalo ngculoza yakho uzawufa. Who do you blame? But I think people living with HIV, the key populations and the public healthcare users in general, our rights are being violated on daily basis by the system and some of the people who work within the system. We are being told of patopile principles, but when we go to facilities, honest, they don't have name tags. And it's difficult for us to name and shame them when they do all these violation of human rights. And as the people, we do not know what to do. You know, before I read here, in Sunday morning, I received a WhatsApp text from another family in Nelson Mandela Metro. It's a voice note. Anele wethu, brother wam was working eLimbombo, and what default eLimbombo waphela umsebenzi. Now he has moved to KwaNobuhle. He went to Silvertown Clinic for a treatment because we realized ukuthi he had defaulted for a very long time. Upon his arrival at clinic, he was told ukuthi he is not going to be helped because akanayo transfer letter. He was told to go back to Limbombo to collect a transfer letter, and he's going to get services. And all what I could do was to call Umama Sonia Lupondwan as the district health manager and said to her, Mama, can you please help here? And then Monday morning, the guy went to the clinic. He got 1 month's supply of his treatment. But the question that I'm asking myself, how many people living with HIV who are going through that every day in different districts of our province? And those people are not fortunate to know someone from Ritshidze or from TAC where they can share their challenges with. And at the end of the day, people living with HIV, as much as we have a largest ART program in the world, but we're still experiencing people living with HIV dying of HIV-related illnesses. We still see majority of people living with HIV who were supposed to be on treatment disengaging on care because they cannot take it anymore. The frustrations that we experience in our clinics makes some of us to take a decision to say, you know what, instead of me going through this, I rather die in silence. And the majority of these people are churchgoers. They pray every day and every Sunday to God. And the question I'm asking myself, when they die, do they think that they will go to heaven or they will go to hell? Because some of these people are not different from murderers. 1963, Thabo Mbeki is marching in London after utata wakhe Nelson Mandela and others were arrested for a Rivonia trial. He was marching, ikhona video pana, unxibe leather, a black leather, ephethe memorandum. Among other things that he was saying there, uthi, if you are in position of power and someone's life is in danger, you do not use your position to save the life of that individual. You are equal to a murderer. That's what Thabo Mbeki said when he was calling for the world to intervene on the Rivonia trial. That's all what we are asking for. Duty bearers and authorities to say, use your positions of power to save these lives that are being forced to disengage on care because of all these challenges. That's all that we are asking. And we are more than willing to work with you in ensuring that we are saving these lives. That's all that we are asking for. The recommendations are as follows. The Department of Health should ensure all DOH staff acknowledge that it is normal to miss appointments and or have treatment interruptions. People living with HIV returning to care after a late or missed scheduled visit, silent transfer from another facility or treatment interruption should be welcomed with open arms. I'm adding that one. Ensure Department of Health staff treat people in a dignified and friendly manner and investigate any reports of poor attitude rates by Ritshidze and take disciplinary actions where appropriate. Send communication to all sites highlighting that no person living with HIV should be sent to the back of the queue if they are late or for or missed an appointment as per national ART guidelines where no punitive action should be taken. Ensure transfer letters are not be required for ARV continuation or restart. Any reports where treatment is delayed by requirement of a transfer letter should be urgently investigated and disciplinary action taken where appropriate. Department of Health and TB HIV care should implement the 2023 adherence guidelines standard operating procedures with fidelity, including ensuring every person starting ART is provided with good quality fast-tracking initiation counseling session, 1 at ART start and session 2 after 1 month of ART. Taking first viral load as early as possible to ensure providing earlier adherence, intervention support, and earlier access to longer treatment supply at more convenient locations. Actioning an alleviated viral load without delay, including funding and setting up effective abnormal result recall system and providing quality enhanced adherence counseling when appropriate. Actioning a suppressed viral load without delay, focusing on immediate assessment, offer an enrollment into repeat prescription collection strategy of choice the month after viral load is taken. All facilities implement 2023 re-engagement algorithm, including appropriately differentiating services for returning people living with HIV. Ensure Department of Health and TB HIV care staff provide accurate and easily understandable information on treatment literacy and adherence, and the importance of an undetectable viral load through consultations, counseling, and outreach. Ensure that treatment literacy information is provided at health talks each day at the clinic. Ensure that Department of Health and TB HIV care staff explain viral load test results to all people living with HIV properly in a timely manner. TB HIV care should ensure that TB HIV care staff acknowledge that it is normal to miss appointments and or have treatment interruptions. People living with HIV returning to care after a late missed scheduled visit, silent transfer from another facility or treatment interruption should be welcomed. Ensure TB HIV care staff treat people in a dignified and friendly manner and investigate any reports of poor attitudes raised by Ritshidze and take disciplinary actions where appropriate. Support with training and monitoring of DOH staff at facility level on the revised 2023 re-engagement clinical and adherence guidelines standard operating procedures. PEPFAR should fund an expansion of people living with HIV and key population-led treatment literacy efforts across all provinces through training, education, localized social mobilization campaigns. We're going to the next item.
The next group of issues are those affecting key populations. Most key population using public health facilities to access health services, so it is important that our CHCs and clinics provide friendly, respectful, and safe, confidential environment. Yet despite sensitization, training, and retraining efforts, disrespect and poor treatment of key population remain a common challenge. Ritshidze data reveal that public health facilities, only 26% of gay, bisexual, and other men who have sex with men, 25% of people who use drugs, and 47% of sex workers. Please note that due to low sample size, we have excluded trans people and in some smaller subsections, sex workers from the data set. The majority of key population interviewed did not feel safe or comfortable at the facility. In order for key population to access health services, and in particular, key population-specific services, spaces are needed that feel safe, comfortable, and private enough to disclose you are a member of key population group without fear of judgment, abuse or harassment, or even arrest. Where people do continue to suffer daily indignities of using public health system, specific services remain unavailable. Ritshidze data reveal that very few sites provide key population specific services, and when asked what those specific services are, it becomes clear there is little available. Key population always access basic prevention tools like condoms and especially lubricants. External condoms were only available in 71% of sites monitored. And lubricants were only available in only 29%. Additionally, lubricants need to be put in places that people can take them without being judged, embarrassed, or even outed as a key population. However, in most sites, lubricants were only available in the main waiting area or by the reception or by request in consultation room. When we spoke to key populations themselves, only 25% of gay, bisexual men sleeping with other men we interviewed, and 32% of people who use drugs in public health facilities said they could access lubricants. Not all facilities prioritize offering key population PrEP, despite it being available in 100% of facilities monitored by Ritshidze. While covering a wider and differing set of sites, only 41% of gay, bisexual men sleeping with other men and 15% of people who use drugs interviewed reported being offered PrEP at the facility. pointing to the reality that while PrEP is setting in facility, key population are not always made aware of and actually offered PrEP. Harm reduction services remain out of reach to people that use drugs. Only 17% had been given information on where to get methadone, only 4% given information on new needles, and only 2% were able to access drug-dependent support. Now we move to recorded stories.
The services that I was seeking at Mtata Gateway was PEP. Sometimes you speak to a client and you tell the client that you only want to use protection, but when you are in the field, it's very difficult to uphold those boundaries because they will overpower you. They will do what they want to do because you get in the car with them and you go to a remote location and sometimes this person's home, and so I've been physically overpowered and they have not used protection. So I've gone to seek for PEP at the clinic, but because it was very frequent, they did realize that there's something here. There's something here, and I've also been diagnosed with a couple of STIs that I've went there to seek treatment for. And so I think because of how frequently I was at the clinic, they did suspect something, but they did not know for a fact that I was a sex worker. So I did, and I've also sought services for being assaulted. I needed to be stitched at some point. I needed wound care, that type of stuff.
At first, it was okay because they see me as a female, as a woman. But then when I tried to educate them about the right pronouns to use, or they must just use my name, that's where everything changed. They started calling me a man with boobs, laughing about it, talking about it in corridors. We have that man. But look at her, everyone would just laugh. At some point, a guy came to me. In fact, guys, it was like they were sent by them that, there's that one, so go for them. And they'd be like, free to put this, or and they'd start being touchy. And then when I reported to the security guards, they were like, you are a man. You said you are a man, defend yourself. Went to the clinic staff and they said also, no, you are a man. You said you are a man, and everyone started laughing. It was like it was a joke. And at some point I ended up leaving to go and calm myself down, and then I came back. So when I came back, the service was the same. But then I had to endure because I needed the assistance at the time.
That's when I started using Ritshidze. But also it didn't go so well there as well, because I was caught out again. And the stigma rised where no nurse would want to touch me, and because what if and you'd think that healthcare workers would be the ones that would understand that they won't get HIV from me, like if they wear their gloves or they won't have a cut or something, but that's not true.
I once had a situation whereby I was attending at the clinic attending for a HIV test. I was going for a HIV test, but also trying to acquire the HRT process here in Stanford Clinic. But they didn't offer me anything properly, other than they made me to go around in circles because I was just someone different, and they used transphobic words. They would call me like uputi, even though I tried to explain to them that no, listen, I'm a transgender woman, so my pronouns are her and she. But they didn't. They just laughed it off, which was very daunting for me. And I tried to be patient and try to understand, okay, you know what? These are people I'm trying to get my services here, and then I'll be done and out. But little did I know. And then I went to the reception area of the clinic, Just after I've done greeting the nurse, and then she just went to say, she just said to me, just go to the men's clinic. I didn't even say why I was here. She just said, just go to the men's clinic. And I was like, I don't need anything to do with the men's clinic. You see, that I tried to tell her that, no, I'm a transgender woman and I'm here to ask about, do you offer EHRT process? And then she just looked at me and said, well, we don't do this kind of things here. Other than that, being given the attitude about the nurse and then trying to ask to the security guard, but where do they take blood samples here? And then the security guard just said, I and I'm like, sorry, I'm not a booty first of all. I'm a transgender woman, so I need you to acknowledge that. And then he just went off, he said, and then he cussed at me, and I was like, wow. And then being human, and I just went upset and then just left. I didn't even acquire those services that I wanted. I didn't even get them, so I just left everything there.
Oh, ndihlala elibode elangeni. Iklinikhi yami endiyisebenzisayo yiMalusi. Isevisi endakhe ndayifumana phaa ndakhe ndaya eklinikhi. Kwatshiwa xa ndiyotesta phaa ndizayifumana njani i-HIV ndilala namanye amantombazana, which is loo nto yandiphatha kakubi ne. I-toilets, I'm not comfortable using i-toilets zamantombazana because I'm a trans man, and I'm not comfortable nakwezi zamadoda. At least if bekukhona eza toilets ze-LGBT yabo benzoba comfortable. Eyona nto yandiphatha kabuhlungu leyo. Ugezelo noba ungononga indoda, yazi loo magama, ungononga indoda bayakumispronounce. Yeah, laa nto uba at least babe nee-toilets ezezethu. I'd never go back to Malusi Clinic because they do not have privacy, confidentiality. That's why I'd never go there. Laa nto uba kuthiwa ungononga indoda ayikho mandi kum. Uyamazi nonga indoda into? I don't know once I understand sanjani, but in Xhosa umuntu who looks like a man. So they mispronounce abantu. So I do not like Malusi Clinic.
Well,
they are very harsh when it comes to sex workers. They're very harsh when it comes to gay men. They're very harsh when it comes to teenagers that come in with sexually transmitted diseases or pregnancies or whatever. So when something is outside of the norm and what is socially acceptable in society, they can be very, very harsh. I was called names. As I was going in, I was serviced last sometimes because I'm always here and you know the procedure and just sit down, you know, we gave this to you last week. Those are the kind of things that they would say to me all the time. And so the discrimination was very real, but it wasn't an isolated event, because there are people that come in looking very typical like sex workers, you know, but I've also realized that you have to maneuver the system. If you get beaten up at 1 a.m., don't go in at 1 a.m. when you're still wearing your clothes. But that's when I used to be in the streets to work. I don't work in the streets anymore. But you know, you wear very provocative clothing when you're trying to attract your clientele base. And so if you go straight into the clinic, no, if you go into a hospital and you are still like that, then it's not wise, because that's where you will attract the attention to be discriminated against. And so I already knew that going into the field. And so I knew that I needed to go at a decent time and I needed to dress very modestly and carry myself very differently. And I think that's what helped me, because my older sister was also an SW, a sex worker, before I got in. And so I'd already known all of those tips, that don't go in the night. Wait until the morning. Don't put on makeup. Don't wear sexy clothes. Come in looking like a very, you know, decent, normal girl, basically, so that you can get the service. But unfortunately, because of the frequency, I did feel that they were very suspicious of me, and then they started treating me differently.
Molweni, Ndisebenzisa iNgangelizwe Clinic.
I use Ngangelizwe Clinic.
Ndi-sex worker.
I'm a sex worker.
I-problem yam phana okokuqala ndisebenzisa ii-condoms ne.
My issue first, I use condoms.
Phana okokuqala ndafike ndacela i-box yee-condoms.
I went there to ask for a box of condoms.
Ndaxelela into yobana uba hayi mose ndikhulele phana elokishini eNgangelizwe. So iindaba ke ziyahamba abanye abantu abaphangela phaa eNgangelizwe sasikhula nabo.
So I grew up around the area of Ngangelizwe and they know me at the facility.
So ndiyazi ube ezi condoms ndizozenzani phaa.
And they know what I will do with the box of condoms.
Kwathiwa hayi mandihambe ndiyaziphangelela so mandizithengele ii-condoms ndingazogqiba ekliniki.
So they told me that I work, so I should go go buy my own condoms and not take condoms free from the clinic.
Okwesibini ndisebenzisa ii-contraceptives.
Number 2, I use contraceptives.
Ndisebenzisa i-depo.
I use depo.
Kuthanda ukuthiwa phana ayikho.
They always say it's not available.
Ukuthiwe uzotofa noba kungenari.
They're telling you that they will use anything like Narasterid.
Inara ayindivumi ke indisa kwi-periods for 30 days.
And the Narasterid does not work with me. It allows me to go to my menstrual pain for too long.
Xa ndikwi-periods ke ngoku umsebenzi wam uyama.
And when I'm on my periods, I stop working.
Ndatshintsha ke ngoku ndayeka uhlala apha ndayohlala kuTsolo because phana khona umuntu endimaziyo phaya lesibhedlele.
All in all, I had to relocate from Ngangelizwe to Utsolo because there's someone who knows me and understands.
Yandiphathela ii-boxes zee-condoms, idepo isoloko ikhona kwisibhedlele sakhe ntofe ngayo.
They bring me condoms always, and even the injection depot is always available at the hospital.
This one time ndandikhe ndaya eNgangelizwe ndine-infection.
So this one time I went to Ngangelizwe trying to treat an infection.
Ndafika phana kwabuzwa uba iphi ipartner yakho.
So I was asked for my partner.
Apho ke i-infection ndiyifumene kwi-public toilets kwi-club ekuTsolo.
So I told them that I got the infection from the public toilets.
Nalapho zange ndincedwe ndaphinde ndayoncedwa yile tshomi yandinika idoksi from isibhedlele sayo.
Even then they were not assisting me. I ended up going to my friend back to Tsolo where she gave me a doxy.
Yes.
Thank you.
Molweni. Ndisebenza eSatron Clinic.
I use Stanford Clinic in Mthatha.
By 2020, ndaye ndaya eclinic.
In 2020, I went to the clinic.
Ndiyochecka ishimbilo yam.
I went there for a normal checkup.
Xa ndifika phaya ndafika kwathiwa mandiye kwi-men's corner.
When I got there, I was told to go straight to the men's corner.
Apho ndifilishe ndikhululekile.
I did not feel comfortable with what they were saying.
Ngoba I'm gay.
Because I'm gay.
Ndafika phaya lo mfana wandibuza uba ithini into yam apha.
When I got there, I met a male person who asked me what I was doing there.
So ndamxelela uba andiziva right ndizotsala amagazi ngayo yonke into andijonge yona.
I told him that I'm not feeling well, so I'm there for a normal checkup.
Lo mfana wabiza omnye apha kule men's corner wabiza omnye back.
So he then called another person to the consulting room.
Bathetha bahleka but uyambona lo mjida uzodlala ngathi apha.
So they were chatting among themselves and laughing too, telling each other that does the other one see the man but what he's doing here.
Wathi omnye uzoyekela ungaguli lala namanye amadoda.
And the other person said, why would I not be sick when I sleep with other men?
Ndaphuma apho ndingakhange ndafumana ncedo.
So I had to leave without receiving any services from there.
Ndabuya the following week again.
So I went there the following week.
Kuba ndiziva right.
Because I was not feeling well.
Kwakhona ndifike ekseni apho.
I got there early in the morning.
By 6 o'clock.
By 6 o'clock.
Into endayibonayo mna phaya ndabona amakhadi egqithiswa ebantwini thina nje besifolile abafike emva kwethu bagqithisa amakhadi ebantwini abangaphakathi.
So I noticed people were passing on their clinic cards and they were taking people from the back and leaving us behind.
thina sihleli pha ngaphandle
and we were sitting just outside idly.
akho mntu sincedayo.
No one was coming to help us.
Ndaendaba ndixelela itshomi yam
I ended up telling my friend,
but andizukwazi uyibiza ngegama.
which I cannot mention the name.
Yeah. Ndancedwa yiyo
So I had to receive help from my friend
ukuze ndifumane uncedo
so that I can get the help I wanted.
because
Molweni. Mandiwagawule ndiwarhuqa. I'm gay. Into eyenzekayo yandehleleyo. I've noticed that ndinengxaki kwipenis yam.
I'm gay, and I noticed that I have a problem in my penis.
Kanti yi-infection.
It turned out to be an infection.
And ke thina singamadoda sinengxaki iklinikhi yoyoyika.
And us as men, we have a problem of being afraid of going to the clinic.
Ndaya ndithalalisa kukuhlala ngenxa yokoyika.
I went there even though I was hesitating because I was afraid.
Ndaphetha ndizincama ngoba sendibona uba kukho into ophumayo ebubomvu apha phambili and ndichama kabuhlungu and uyatshisa umchamo wam.
So I ended up going because the pain was getting severe and there were fluids coming out of my penis.
Ndaya ke kule kliniki iseGateway.
I went to Gateway Clinic.
Then xa ndifika ndivuke ekuseni bendivile mos uba kuthiwa kuyavukwa ekliniki, so ndafika pha ngo-6.
So I heard that you had to wake up very early to go to Gateway Clinic, and I reached there at 6.
Yayingumqenqgelezi njengoba ndibona la post phaya njengoba abantu befolile kukho nabantu abadala pha nibona. Nam ke ndafika kunjalo ndafike ndafola iline iphumele ngaphandle.
The line was very long, as you see in the poster in the room. Even the elderly people are queuing in the same line.
Yebo safola ndafola ke ndabamba elo xesha uba and into ndayinotisayo ngoba ndabuza uba aba bantu bancedwa apha ngaba like ndifuna uqonda uba le nto ndiyizeleyo mhlawumbi kuye kufolwe njani okanye mele bandifola kwenye indawo okanye ndifole njani.
So I had to ask the people that were queuing in the queue, trying to find out if the lines are being separated according to what you are doing at the clinic.
Hayi ke ndave kwathiwa wonke umuntu ufola kule line iwanda so singaqhubeleka ndafola.
So I was told that there's only one line, everyone choosing the same line.
Hayi ke sahlala ke elayinini oko ke ucinga ke umuntu ebetye isidudu ekuseni.
So we had to wait there for too long. Imagine arriving there early in the morning.
Uphinde ucinge khona amaxhegwazana abanye ke baze ngezinye izifo zabo mhlawumbi abanye baneswekile zabo ne-chronic disease abanazo.
And you'd notice that the line is full of elderly people, and even other people have other sicknesses like chronic.
Kwamna lona ndiyaphenika ngoba kaloku umchamo wam uyanditshisa and akululanga uba ndichame and sendifuna kwa uncedo ngokukhawuleza.
And even I was panicking because the urine in my penis was getting quite hot, and I wanted urgent attention.
Lihambile ke ixesha ke ndithe xa ndifika enantsikeni egeyithini ndizawubuza ke ngoku ku-security ukuba ndingancedakala kweyiphi na indawo ngoba kaloku xa ungena uyakwazi like njengoba ingaba abantu baye bame pha bagade abantu ne-crowd le ifolileyo ingangeneleli abanye abantu so ndaqoma mandibuze kuyo.
So while waiting, I was panicking, feeling the pain, so I had to go to the security to ask where can I go to get some help.
Zange ndilithande uncedo layo waske wandijaja ngoba endibona uba mhlambi ndisisitabane, I mean ndi-gay and ihlobo wandibiza ngalo wakhomenta ngento yoba usisitabane kwathini.
So I didn't like the treatment I got from the security because he was calling me names like Istabane.
Waske wathi mandiske ndiye kwi-men's corner.
So he then told me I should just go to the men's corner.
Kwi-men's corner ndiqale ndithe ndisaya kwi-men's corner uba ndiqonda uba andiyazi ndadibana nelinye inesi uba ndifuna uncedo.
While trying to look for the men's corner in Gateway Clinic, I met with one nurse trying to get help.
Ndaske ndaphinde ndabuyiselwa emva.
The nurse then turned me back to the queue.
Ndakhe ndaphinde ndabuza kwabanye abantu abafolileyo elayinini kanti men's corner ithini into yayo kuncedwa abantu abanjani.
So I had to ask again on the queue what services are being offered at the men's corner.
Then ndacaciselwa ke uba ngamadoda kuncedwa amadoda angekho comfortable like kuncedwa amadoda so that bazoba comfortable ukuncedwa bakwazi uthetha imbilini le baze ngayo.
So I was told they only assist men who are going to be comfortable talking with other men about their reasons why they went to the clinic.
But ke into enza ndayenziso ndaphinde ndabuyiselwa emva.
But all in all, they turned me back from the to the queue.
Yiloo nto ke into zange ndiyithande but ke ngoku kuthe egodukeni kwam because ndave ndapenika ndavele ndadikwa ndazike ndazama ndafowunela ubhuti wam wazama undizamela undisa efamasi apho ndafika ndainjekthwa khona ndanikezwa neepilisi.
So all in all, I panicked because I was feeling the pain and not getting any help. I had to call on my brother, who then took me to the pharmacy. Then I received an injection there and treatment as well.
Security lo ndandibuza kuye lo wandigxekayo ngobutabane endithuka endixelela ngobutabane ndadibana naye kwenye indawo ekonwatywa kuyo then ke ngokule ndawo ekonwatywa kuyo nako endithuka endihlasela ngaloo nto uba niyagula zitabane ndini.
I then met the same security from the clinic in a place where we go and have fun, where he then attacked me, even then telling me that we get sick because we are gay.
So into bendirhalela nam khe ndiyaze uba pha ekliniki abantu abasebenza ekliniki umzekelo uba ngusecurity ayikho into abayifundiswayo mhlambi njengoba bephangela bephangela kwa-health umzekelo indlela yothetha nabanye abantu.
So all I wanted to know was that at the facilities, is there no training on the way to talk to people, or even the securities, are they not trained to address people well in the healthcare facilities?
But again,
no, there is no Mandela who liberated us. We had to take up arms and fight against the racist regime because we fought for freedom. And that freedom, when we talk about political freedom, it also talks about the rights of the people. I'm asking myself, how are we going to deliver quality healthcare services and respect the rights of the gays, lesbians, MSM, people who are using drugs, sex workers, and all what have you? How are we going to respect their rights if we do not respect their health rights? We are in a stage where Africa and its people is rejecting their own children. Africa and its own people, because of our religious and cultural beliefs, we are judging other people for the choices they have made in life. Yet in the same country, we've got a constitution. And in the constitution, we've got to section 10 that talks about the Bill of Rights. Freedom of association, freedom of choice. Yet, when people are going to health facilities, instead of us giving them the services, we start preaching for them. To say, hi, if you are terminating a pregnancy, you won't go to heaven. If you continue to be in this gender, God will judge. Who are you? Because these people are not hired there to preach. Them preaching is not part of a standard operating procedure. Their duty is to provide services to the people. And because of that, many people decide not to go to health facilities. But also, we, as I said earlier on, we've got these security guards, now cleaners, abazenza ones. You know, ANU11 in Motherwell, a couple of months ago in Port Elizabeth, a person went to the facility. Then the person was insulted by a nurse inside the facility. Without a nurse knowing, this person stays opposite the facility. The guy was insulted in front of everybody. And then the guy went home to take his pistol and came back to the facility and said to the nurse, "Can you repeat what you said to me?" The facility was closed. And nobody cared to know who was wrong or right. By the mere fact of this guy bringing a firearm inside the facility, he was judged that he was wrong. And the facility was closed for 3 to 4 days because the nurses were traumatized. Just of one incident. How often are black poor children are being traumatized in our health facilities? Nobody dares to care about the trauma the majority of the people are going through. Nobody cares about what we go through when you are being insulted in a facility or discriminated. We are expected to take life as normal. Yet, we've got a beautiful constitution, all these rights, but nobody cares to say the rights of the people are protected. As Ritshidze and as TAC, including the HIV sector, including the key population sector, we are more than prepared and willing to work with you in terms of sensitizing healthcare workers, security guards, and cleaners in order for them to understand the rights of the key population, in order for them to understand issues so that at the end of the day, people do not find themselves being misgendered. We are here. We've got a program that we are running to educate even the nurses so that if Anele comes into a facility as a gay person, Anele is not going to be judged or being misgendered, but Anele will be made to feel as a dignified person whose rights are protected, and also Anele will be made to feel as a human being through the quality of services that we get from our facilities. That's all what we want, because if the majority of the people are sharing all these frustrations, therefore, those who do not want our government to implement NHI will use all these testimonies as a weapon against our government and as a reason why our government cannot be able to implement NHI. And if we do not fix these problems, soon or later, the vast majority of the public healthcare users of our country will say to our government, to hell with your NHI, to hell with anything that you are bringing to us, because it does not work for us. Yet government is not the one who is making all these violations of human rights. And the question we're asking, what are we doing about that? We need to do something so that when a community member wakes up going to a clinic, you do not wake up in fear of, I wonder what is going to happen. What am I going to go through? Which nurse is going to insult me now? Because that's what many people feel when they are supposed to go to our healthcare facilities. You're going there to seek health services, but you know what you are traumatized. And you are not given a treatment of a trauma and mental health. We are being often told about mental health issues, yet the same people who are telling us about mental health challenges are causing a lot of mental health for us when we go to those facilities. We need to work together on this so that what is in the Constitution, what is promised in the Constitution, all people of our country are able to realize it, not as a dream, but something that is happening on the ground. Same applies to what is happening at Ntsele, at Gateway Clinic. We cannot have facilities that are perpetuating medical xenophobia or medical exclusion, where if you're not coming from this village, you are the last person to be served, and we start with people of this village. That is the violation of the rights of healthcare users. Same applies to what is happening at Gateway, with the hope that abaphathi abakhoyo apha will try to list all these issues that speaks to each facility and try to address them. But also, we are not intending ukuthi when these issues are addressed, a situation becomes tense between us as the users and the providers. Because one of the things that makes many people to keep quiet is because when they speak out in these facilities, they know that they will be isolated. They will be identified and they will be denied services. So that's why at times people feel like not speaking out. Even the complaint boxes in our facilities are not helping us. We write these complaints, facility managers are opening this complaint box, at Anele ucomplain about Sister Ndimpiwe, uyoxela Sister Ndimpiwe, jong Anele ubhale ntoni ngawo. When Anele goes to a clinic the following day, Sister Ndimpiwe has an attitude towards Anele. We are often told, when you've got problems, lay complaints, but complaints are not being resolved and the feedback is not coming back to us. All what is coming back to us as the users of services is bad attitude and bad treatment. We need to resolve this. Before 1994, I would have understood all these problems which have been mentioned here, because we were governed by an illegal government of the white people who stole our land through the barrel of the gun. But now we are being governed by the government that we voted into power through our acts. And if the government in power now has been voted by us, we need to see and feel that. To say this government is defending and protecting our rights as black people and as people of this country. We cannot go on like this, colleagues. This needs to be resolved. The recommendations are as follows. The Department of Health should ensure that all clinical and non-clinical staff, including security guards across public healthcare facilities, are sensitized on provision of key population-friendly services to ensure a welcoming and safe environment for all key populations at all times. Key populations must be involved in the implementation of these training modules. Any reports of poor staff attitudes, privacy violation, verbal or physical abuse or harassment and or of services being restricted or refused should be urgently investigated. Department of Health and PEPFAR should expand the Centers of Excellence model to ensure that at least 2 public health facilities per population in OR Tambo serve as a key population designated service delivery centers. A minimum package of services should be made available at these facilities as outlined in the State of Health report. Easy referral and adequate resources, including transport or money for transport, must be provided for people to take up these services. PEPFAR must support these facilities with additional key population-friendly staff and the resources to provide comprehensive health services to the specific key population being served. Ensure that HIV prevention tools, including lubricants, external and internal condoms, PrEP and PEP, are made easily available at all public health facilities. Make available external and internal condoms as well as lubricants in a range of spaces across the facility, e.g. waiting areas, toilets, gate, pharmacy, consultation rooms, quiet areas out of sight, so people can freely and easily collect them. Ensure that PrEP is offered to everyone, including key population who are not living with HIV or test negative for HIV, with information shared on its benefits. Ensure that all facilities provide gender-affirming services, including using trans people's correct name and pronouns, providing a gender-neutral toilets for trans people, respectfully asking trans people which color folder they are more comfortable using, for an example, pink, blue, or purple. Ensure that trans women are not made to use men's corners. Maintaining privacy and confidentiality, additional healthcare workers and clinic staff should not be called into consultation rooms under the guise of helping, when often this is to mock and judge trans people. We're going to issues of infrastructure.
Thank you, Chairs. We'll now move to the set of issues that talks about infrastructure and cleanliness. The country's load shedding crisis negatively impacts the provision of healthcare in our clinics and can often lead to people waiting much longer to collect medicines or consult with a clinician. In OR Tambo, the most common challenges include data capturers not being able to capture information, creating a backlog and impacting follow-up with people who have missed appointments, and other recall systems, medicines and vaccines getting spoiled, and delays in finding files when filing rooms are in darkness. Generators at each facility could resolve these challenges, yet only 50% of facilities reported having a generator that is working or has fuel. 79% of facilities monitored in OR Tambo were observed to be in good condition, which is up from 60% last year. The reason for poor clinic condition observed in 3 remaining sites that are outlined in the table. 93% of facilities reported needing more space, with waiting space, filing space, and rooms for private HIV testing and counseling, given as most common things facilities needed extra space for, impacting negatively on congestion, TB infection control, waiting time, and privacy. On overall cleanliness, 78% of public health care users reported that facilities were very clean or clean, while 5% reported that facilities were very dirty or dirty. 71% of Ritshidze observations found that toilets were in bad conditions. There was no soap, dirty conditions, no toilet paper, no running water, given as the most common reason for the bad condition. We now move to the recorded stories.
Into endinothisileyo xa ndifika futhi again phaya kwii-toilets zakhona akukho manzi. Fumanisa uba akukho kwamanzi ezizinkini. Ndachama, andifumani manzi akuhlamba zandla, ndafumana intwanyana yayincinci ndazosula njengayo ndahamba naloo khontena injalo ndingayanayo ne-toilet paper uba ndosule loo khontena. Naso ke isitori sam. Indiphethe kakubi as a patient, especially ukungabikho kwamanzi, especially amanzi nje nokungcola kwakhona. Into endayifumanisa kukungcola namanzi awekho kukwisa kulaa sasibhedlela sase-Flagstaff. Because kaloku fanele kube toilet kube khona amanzi, kube clean futhi. Sasisokola sonke phaa sizipatients sibaninzi, abanye abantu bekhohlela phaya, abanye bechama, nabo betshintsha nabantwana iipampasi phaya, akukho manzi. Nantso ke into yandiphatha kakubi endayifumanisayo nje. Ndazibuza uba inoba kutheni mhlawumbi kuba kungabikho manzi futhi nokuthi kungcole ke. Ingaske futhi kulo mcimbi wamanzi ke kuyiwe kwamasipala kuyocelwa uba like namanzi etanki. Ucela uba ngoko bakwazi uba kuncedakala abantu. Azinto mna ndingayicebisa.
La clinic leyana intsha yalapha eZimbabwe. Mamele ke sisi. Ya. Sancama yayikade isiza iclinic apha elalini komnyumzi apha. Uyabona le nithi intoni? Yatso moyibhayile. Asiyazi bayexwa intoni. And kudala siyicela iclinic kule lali manje sithenjisa umgunyathi. Because into enizithethayo anizenzi niyazithetha. Ilali zale ndawo zinkulu. Uyabona abanakwenela abantu ngeclinic enye kupain. Uyabona into yokuqala isikhalazo sami ugqirha ohamba pha. Uyabona ufika ngabani ixesha, sorry andimazi noba ngo-2 noba ngo-1. Uyaqonda ya afike abantu bebaninzi. Uyaqonda angakwazi ubagqiba xa kwaba mnyama kutshayiswe. Uyandiba le clinic udala zayo le clinic know about more than 5 years kuthiwa hayi nizawuyenzelwa akenziwa nangoku. Sinawo nomhlaba apha thina ninzi umhlaba apha sisenalo. Into nayo into ethethwa ngurhulumente mandi nje uthetha into bangazenzi bangazilandeleli.
Ndiklinika entshele. So ndivuka apha enhlekiseni ndileqa iteksi kwaPain ehamba nge-5 to 7. Xa seingenile ke le teksi ufika pha ubhalisela phandle, uhlala phandle, yonke into uyenzela phandle, kuthandazelwa phandle. Then xa uyobhalisa ke ngokubhalisela ubuzongena inesini kuthiwa makuzethu ngexesha nisuka phandle ningene. Ufike napha mhlawumbi ukuhlala ufumanisa uba nalo mntu ubhalisa uncokola nalo usecaleni kwakhe, then ubhalisa wawugqiba ubhalisa uphinde uphume uhlale phandle uzoya enesini. Mhlawumbi xa ndifika enesini ndifika inesini ezistresi zayo uthi usatsho ubana hayi ke namhlanje khange ndilale into ethile, ayikho ke yepilisi yanto ethile uzayifumana ekhemesti. Okanye uthi usazawuqhubeka nebali athi kancinci nje aphakame xa ebuya ubuya sefuna ungenisa omnye. Sentsho uba eyona challenge sinayo entlekiseni yinto ubana asinayo indawo yekliniki sixhomekeke kuntshele, then kwantshele kuyanetha uphandle, kuyabanda uphandle, akukho ndawo le yoba sihlale. Kwenziwe ishelter like inzothi ziplastic because kubuyiswe intsimbi, then kwasithwa like usithela nje umzimba umphambili wonke ungaphandle. Xa imvula isiza ngapha iyanibetha imvula, xa isiza ngapha iyanibetha imvula. Ayikho indawo yoba nithi nizohlala ngaphakathi. Kuyivula xa uye ekliniki, hayi mani phandle zobafike nibe free mhlawumbi zonke izinto ufike ngoso ukhona ubamba igazi mhlawumbi uzofika kule nesi ingenathando lwakho, uthi ngexesha ubuye uqonda uba ndiyocela uphila uske ubuye ugula mo. Into ye-attitude yestaff ke sisi mandenze nam ndikhe ndivuke ndingekho mudini yokuthetha nomntu, uyayibona. Mhlawumbi naye umntu zoke enaloo nto mhlawumbi iye yamhlupha lo mzuzu, then aye ebantwini xa sefike phambi kwakho akuzukukhaleza ayenze laa nto uba okay ngoku andisekho ndlini, laa nto ibindiqhubekise endlini mandingayibambi. Yena uba nalaa nto ithi mhlawumbi ukhutyekiswe ndim, so xa efika kuwe ngoku izoba ngathi ubona kwamna, kanti bekufanele uba uyatshintsha xa ephuma endlini esiya emsebenzini. Immediately ephuma ezawungena emotweni ifuna emoto, wenza indlela yoba manditshintshe ngoku ndiyodibana nabanye abantu engengabo aba bandenze le nto. So ibingase ibe yindlela nje yokubana umuntu ayazi uba ngoku ndiyosebenza nabantu, mandibe live, mandibonakale ndinoncumo noba imeko ayitsho, but mandizame laa nto yoba umntu afike ndi-live.
Molweni, ndizawuthetha ke le nto ndizawuyithetha enye ke mhlawumbi le sithi xa sidibene singabahlali siqomba siyayinqwenela. Ayivakali? Hayi ke ndithi eyona nto ndizayithetha ndim lo gqiba uthetha apha laa tata uthi urhulumente uyazithetha izinto angazenzi. Umhlaba sinawo pha nyhani mkhulu, bekugqitywa ucandwa umhlaba apha wekliniki ayikakhona namhlanje, andaba kunyaka wesithathu nalo, ndiyazi le nto inzima. Ngoku ke eyona nto ibalulekileyo mandiqala apha kuqala phaa eMaxhwele ikliniki yakhona hayi itorho isanda kwakhiwa intle iklini futhi into engamandla ogqirha mnye ayofika ngo-1 okanye ngo-2. Thina ke sisuka kude uba sisebenzisa nemoto elayisha istafu, ngoku ke siboma sayishiya kulethi ngoku sawushiyeka apha asinawufika ngenyawo ekhaya. Ngoku ke nto ibalulekileyo ke cela ke mna ke senzelwe noba kule nto kuthiwa yi-mobile clinic unojikeleza amane efika, sinayo neholo phayana ekungathi xa yakhiwa loo kliniki siyocela kuyo necawe zezethu zezalali singacela kuyo. Nantso ke into engamandla esishota ngayo. Kukho amaxhegwazana apha awukwazi uhamba and akukho mali, imali le mali yegrant kuthiwa hayi uyenza le mali. Bondla abantwana bazukulwana babo because kaloku abonina basebenzi, so ke ngabanamali yokukhwela bayekliniki. Naso ke sami isicelo sicelwa ke kwayi-community leya yasezimbane entlekiseni. Mandingawagqibi.
Molweni, ndisuka eFlagstaff, ndisebenzisa iFlagstaff Clinic.
I come from Flagstaff. I use Flagstaff Clinic.
Okokuqala ndizoqala phaa kwi-toilet. Yho, simdaka, akungeneki, akukho manzi, akukwazeki nje okungeneka at all. Toilets are too filthy.
First, I will start with their toilets. They are too dirty. They have no water. and we can't even enter inside them.
Okwesibini, xa ungena ngaphakathi, kukhona indawo obhalisa kuyo pha, like kanje. Indawo obhalisa kuyo, kulapho ku-screenwa khona, i-pharmacy ngapha, kwenziwe enye into ngapha yi-queue yabantu abahleliyo phana ngazi benza ntoni. So zininzi into ezenzakala kulaa ndawo. So uye ungene ngaphakathi, ubuye uzothatha i-treatment yakho apha ngaphandle. So loo nto ibonakalisa uba nje umntu akekho into yonke into eyenzakala ekliniki uyakwazi ukubona nanoba ngubani xa uthatha i-treatment ubuthatha i-treatment yantoni.
Secondly, one other issue there is that the facility is in a hall setting. All services are done in one room. And as a result, when you want to access private services, you are unable to. All the people that are queuing inside the hall, they see what you are there to do at the facility.
So lento iba yingxaki loo nto izokwenza noobhuti bethu ngoba ibakhulukazi lapha kuba indaba bangafuni uyothatha i-treatment izinto ezikanjalo sisazoba nengxaki nje futhi abantu abangakwazi uthatha i-treatment ngenxa ye-monsters eenurses zethu esinazo because they are monsters abakwazi ukuthetha nabantu.
And that is one of our biggest issues there at that clinic. And as a result, many people, especially male people, are unable to go collect their treatment at the facility because they are afraid people will see them. And secondly, their attitude towards us and the way they are treating us indifferently is not conducive, or we are not happy about it.
I remember this other time, ndaqoka kuba ndihambe. I-date yami yayisekushiyeka iintsuku ezimbini bifike, so I have to go ekliniki ndiyocela iipilisi because I'm using ARVs.
I remember this one time I had to urgently go to the clinic before my appointment date in 2 days to go there and ask for my treatment.
Bangxolisa ke bangxolisela uba kutheni ndizofika i-date ingekafiki, and I was like, niyathetha umuntu efike in time, efike ixesha sedlulile, niyathetha umuntu efike ixesha lingekafiki kufuneka senze kanjani, and ndaphetha ndihamba ndingazifumananga iipilisi ezo.
I was shouted at. They were asking me why did I come before my date, and I had to ask them why are they shouting at me when they shout at us while we missed our date, and they shout at us again while we come before our dates. What do they want us to do?
Again, there was this other time, ndise umntanami oyintombazana wayethi ke wayenengxaki yoba wayene-infection wayevele nje abe ne-discharge ndamsa ke ekliniki.
This one time I went there taking my daughter. She had an infection.
Unesi was shouting at her ethi nizothini ungabi ne-infection nilala namadoda nibancinane.
And the nurse was shouting at her, asking why won't she get any infection because they are sleeping with men while they are young.
Ndaye ndabhlungu ke ngoba ndaye ndambuza lo nesi uba xa ngaba uzomthethisa if lo mntwana bekuthiwa uberechiwe bezokwazi na ukuthetha atsho uba urechiwe ngendlela usuthetha ngayo, ngoba noba bekuthiwa berechiwe bengekazakwazi to come clean atsho uba ndirechiwe ngenxa uba uvele wathethiswa kwangunesi lo bekufanele uba uyamcomforta.
So I felt so bad. I even asked the nurse if what happens if the child was raped. Would she be able to talk about the rape if she's treating her like this?
Enkosi.
Thank you.
We going to recommendations. I'm worried about into ethethwa ngutamkhulu nosisi, but also issues of lack of confidentiality and privacy in our health establishments, including issues that are related to infrastructure. As I said before, I am also serving as a board member with Office of the Health Standards Compliance. Our duty there in that office is to inspect and enforce compliance on health establishments around norms and health standards. And also, we issue a certificate which is valid for 4 years to all health establishments that are compliant. And in order for a health establishment to qualify under the NHI fund, the Office of the Health Standards Compliance must issue them with a certificate of compliance. Out of 3,800 public health establishments that we have in South Africa, if about 700 of them are compliant, they are too many. If 700 is compliant. I'm not talking about hospitals here and GPs, including private hospitals. I'm talking about primary healthcare as well as community healthcare centers. If esinazo, the 700 is compliant on issues of infrastructure needs. And the question I'm asking myself, how is the government going to implement NHI if a majority of our health establishments are not compliant? Including this thing of our government and treasury of the supply chain management. Iketile uyifumana pha kwa checkers get 250 uyozithengela, but xa uyithenga through supply chain uyifumane nge 3,000 rands. But also we know, colleagues, that the Minister of Health does not have enough powers in provinces when it comes to budget allocation, hiring and firing of staff, building of or refurbishing health establishment, purchase of medicines and goods. Those powers lies with the province. And in Dabayok, even le yase village clinic, in order ukuthi yakhiwe, we had to take the National Department of Health to court, and we had a court agreement that was settled outside the court to say, Atu Minister, no, TAC and Section 27, don't take this case forward. I am going to build that clinic as the minister. And the question I'm asking myself, what is the province doing about this? As much as other people are worried, the former HOD, Dr. Roland Wagner, is removed by Oscar Maboyan. Roland Wagner is not different from Tobile Mbengash, the former HOD of these provinces. They are the same soup with the same ingredients, but what is different, they were dished in different bowels. They failed the people dismal. And we cannot feel sorry. Eastern Cape, there was another minister here who bought trolleys for people abagula, and that was trolleys in Indonesia. We want ambulances. We've got deep rural areas where people travel distances from home to the nearest health establishment. And I'm asking myself, there is no way that we can make mobile clinics available. There is no way that we can utilize community halls, izindlu zenkosi, and other public places for people to go nearer to collect their medication if there is no need for them to see a doctor or a nurse. Why we allow our people to travel these distances just for a collection of medication? Yet we are being told about a people-centered healthcare system. Our healthcare system is not people-centered because it does not take into consideration our material conditions and living conditions as black people. It exposes us to walk long distances for accessing healthcare services. Even when we get there, we experience challenges. By the time you go back home, chances of you not getting those services are very high. Yet if we were utilizing the available infrastructure at community level, make sure that mobile clinics are made available to provide services to the people, it is going to be a win-win situation. But we hope that maybe after this meeting, the authorities from the department, I'm sure this is the first meeting of this kind where the authorities were afforded an opportunity to listen directly from the users of services. Maybe when they go back to their corners, they will pay attention to some of these issues. At least sibe nokwazi ubona uchincho in terms of most of the things that were reported here. So the recommendations are as follows. The Department of Health should ensure that all public health facilities have a functional generator with sufficient fuel and rechargeable bulbs so that health services and administrative work can continue during load shedding. ensure that all public healthcare users are consulted, tested, and or counseled in private rooms. Carry out an audit of all facilities to assess infrastructural challenges, after which the department should develop a plan in order to renovate buildings and ensure adequate space to provide efficient private and safe healthcare services. The department must publish the audit report. In the interim, provide temporary structures and ensure that more people living with HIV are being decanted out of the facility and receiving longer ART refills to reduce the burden on overcrowded clinics. Ensure that all facilities are maintained to the highest standard of cleanliness, including through implementing regular cleaning rotas. Ensure clinics have resources to provide soap and toilet paper in all toilets. We're going to tuberculosis.
The next group of issues are on TB infection control. In South Africa, around 300,000 people develop tuberculosis every year, and about 56,000 people die. Yet TB infection control in our public health facilities remain inadequate. By following a simple checklist of good practice, including key measures that implemented during COVID-19, facilities can be safer for public health care users and staff. With the checklist in mind, Ritshidze has developed a scorecard and a traffic light system to rate clinics on how good their TB infection control is. Clinics that adhere to all measures are given a green light. Those that are on the right track but still off target get a yellow light. And the red light is given to those that are way off target on ticking the checklist for the 6 measures. In July and August 2023, zero facilities were awarded green light for checking all 6 measures on the scorecard. 12 facilities were awarded yellow light for following about half of the best practice measures for infection control. And 2 facilities surveyed failed altogether at meeting these 6 basic best practice to stop the spread of TB.
So we're going to recommendations. As we are going to recommendations, colleagues, this was the last item. And then after that, we're gonna call on e-leaders of the 4 organizations, each at least 2 minutes, 2 minutes, 2 minutes. And then after that, sizawunikezela kwi-department, and yazi department, how did they arrange ukuthi bahlomle, and then after i-department kwi-district behlomlile, sizayivala inhlanganiso. Andifuna ukuthetha kakhulu ke nge-TB, but all what I can say, TB is not treated with the agency HIV response etreatwe ngayo. Tuberculosis has been there for a very long time. That's why every March 24th we commemorate World TB Day. Many years ago. But if we are to go to the public health sector, we've got few effective TB drugs, and those that are available, they are still very expensive. And then you compare TB and the COVID. The COVID just came in 2020, and it was quick for the whole world to come up with vaccines for COVID. And there is no vaccine for TB, and effective TB medicines are still expensive. That's why Johnson & Johnson keeps on monopolizing the license they have. And then we begin to ask ourselves, why COVID isandufika? Sibese zikhona vaccines, TB is there, azikho effective drugs. It is because most of the times tuberculosis affects poor people. And the COVID does not care, it cuts across. Whether you are rich or you are poor, it affected you. That's why those rich people who are in senior and higher positions, it was easy for them to come up with the vaccines. We had to march to the deputy president in 2021, TAC and other organizations, saying to our government, declare tuberculosis as a national health emergency. Due to tuberculosis, what you did to COVID-19, we saw Minister Zweli Mkhize on a weekly basis coming to TV, telling us about people who contracted COVID, people who died of COVID, people who recovered from COVID. We saw a political will and a political commitment because our government took money from HIV and TB conditional grant in June 2020 by investor with response to COVID. We have seen xana sisiya clinics and esibhankeni xa ungena we are screened for COVID, but when we go to our clinics we are not screened for TB. Because, and yet, if we are to count abantu who are dying even to this year of tuberculosis, more than 53,000 people die of tuberculosis in our country. And if we are to count people who are dying of TB as compared to people who died of COVID, people who died of COVID are nothing as compared to people who died of TB. And as the country, we are not doing anything about that. The only thing that we saw is the department appointing Dr. Nobet Njeka to lead the TB recovery plan. A TB recovery plan that is not well resourced. You go to our hospitals and clinics that have gene expert machines. They are not working. Zihleli laphayana. Either a battery or cartridge or that which is not working. And a lot of money was spent by our government to buy these gene expert machines, but they are not serving their purpose. Something must be done, Sam, in order for us to improve the quality of services. Because if we are being told that our government is a people's government, we need to ask ourselves, who is the government, kahle kahle? If the government is not serving the people. Oh. So the recommendations are as follows. The Department of Health should issue communication to all facilities stating that all windows must be kept open. TB infection control posters must be displayed in visible places in the waiting area. Public healthcare users must be screened for TB symptoms upon arrival. People coughing or with TB symptoms must be seen first to reduce the risk of transmission. People coughing or with TB symptoms must be provided with masks. People who are coughing must be separated from those who are not while waiting. Carry out a full audit of all public health facilities in the province to assess TB infection control based upon World Health Organization guidelines, after which the department should develop a plan based upon the infrastructural, human resource or behavioral challenges found in order to improve TB infection control. The department must publish such an audit results. And that brings us to the end. Now, without wasting any due time, I will call, as I requested, comrades, 2 to 3 minutes, so that sebeyonikeza i-department, emveni koko sityeni, sigodukeni, ngoba abanye bethu basa-driver back to Joburg. And funeke silele eJoburg tonight, because we've got other meetings tomorrow of trying to fix the country and address the problems of the people. We will call upon Comrade Fukama Kuba from Napwa to come forward at a Kaba. Over to you, comrades. Comrades? Going once, going twice, go to Akeko. Oh, sorry, comrades.
Molweni, comrades. Hopefully niyandiva nonke ne. Hey. Sinomceli mngeni omninzi ephondweni. Ndizivile comrades zam zithetha. Okay. Ndizivile comrades zam zithetha. Nam ndizawufakaza endikwaziyo because nam ndiphaya ekliniki. Eziyenzeka izinto manyani, andifuni uxoka bantu abakhulu. Uyabona kukho lo mcimbi we-transfer letter. Umcimbi onzima kakhulu. Njengoba siphayana funeke sikhangele singene kuGoogle. Sikhangele ikliniki eseGoli ukuze sifumane i-transfer letter. Uba uCambridge akhona ebekhona ebezondingqinela ngoba ndiye ndithi xa ndisiva le konsi ndibalekele kuye. uCambridge akhona ke usoloko kuzo zonke ezi province enabantu. Umzekelo besinomntu oseDelft wandidibanisa neCambridge phaa. Hey, safowuna sancama. Ndabuyela back kunesi ndathi hey kukhona lo mntu and akazuphuma lo mntu engaphethanga treatment. Yathi into kunesi, uyabona ke uzuyazi ba uzawuthatha uxanduva loba xana ngaba elahlekile lo mntu uzayo kumkhangela. Ndavuma kuba ndifuna uba aphume engaphethanga ephethe into. Samenzela nyani, xa ndibenzela kumntu ndiye ndimenzele ndithi ngu-transfer in. Nam ndizinikezele uba ndizawuhamba ndiyomkhangela. Enyanisweni sinee-numbers bazondingqinela uDepartment of Health lost to follow abaninzi apha e-Eastern Cape. Ngenxa yoba amanesi ababaphathi kakuhle kakhulu, kuyawushawutwa. And kukhona lo mcimbi besiwuchophele uba umntu xa imislishe nyani idate yakhe abuyiswe emva elayini. Ndingayazi uba iWest ke kulaa klinikhi ndisebenza kuyo ude kuthiwa makame kancinci ngapha kwegeyiti. Sizawuqala sihoye aba bangaphakathi. Sizawugqibela ngabo. Then njengoba sisithi aba sisemzabalozweni funeka silwile ke silwele into yoba aba bantu mabade bangene ngaphakathi. Kodwa ke guys sikhona silapha ephondweni lase-OR Tambo. Ukubana ngaba kukhona imicimbi eyenzekayo elolu hlobo sitsaleleni umnxeba. Ndiyavuya comrade yam xa uthetha ngendaba kaThiye. Ndivuya kakhulu nyani, ingase uThiye nyani abonakale nyani umuntu kumuntu oseGoli because siye sithi xa sisiya kuThiye unesi uthi andizukwazi umnika lo mntu i-treatment because andimazi uba ebesitya eziphi eGoli. Funeke sihambe ke side sikhangele nomcimbi ka-lab track sitshekishe into yoba lo mntu phayana ebethathe nini. Then sithi ana sister kuba ngoku kukhona i-TLD sicela uzuvele umfake kwi-TLD. Athi ayivumelekanga loo nto kodwa ndizawuyenza kuba undixelela njalo. Ndiyabulela kakhulu man zinkokheli zami, enkosi.
Thank you, comrade. So without wasting time, sizawubiza uComrade from Positive Women's Network, uVuyokazi Dabakayise. Over to you, comrade. Vuyokazi Dabakayise. Going once or twakeko. And then akeko, and then sizawubiza uComrade Coceka Gandile from Sanerela.
Molweni comrades. Lo umileyo nguCoceka, ifani nguGantile, uphila gabalala nesandulela Ngculaza, ezazi uneminyaka eyi-12 ngoku, zange walala bhedini. I'm happy that sikule ndawo sonke with i-complaints esizivileyo, and I'm happy that there's also a team from TB HIV Care, net department, with organizations ezisebenzisana no-health. Colleagues, indaba ye-complaints kwi-clinics ingase siyiphakamele because we're trying to work into yokubana singabi nazi-defaulters. We're working very hard into yokubana singabi nabantu abathi ndiyekele i-treatment because of ubani. Ibhlungu into yobana ndiye ekliniki ndicimba ndizawufumana uncedo kodwa ndingalufumani. Also into ye-transfer letters, mna I think ingalula if umntu angathi kwi-facility othi ndimke kwi-facility ebendikuyo ndangayifumana nge-transfer letter xa efika kulaa facility either u-OM or lo nesi usebenzisana naye afowunele le facility ingabi sithi umzekelo thina abantu sisapotayo or like people living with HIV, because what we do, we normally help umntu othi ndize ndingenayo i-transfer letter ndigooglishe inumber and call that facility. But into ebuhlungu is that they always promise to send i-transfer letter kuthi but bangayithumeli. And ibuhlungu because laa mntu uzawujikisa umzekelo uzawuba yivisitor kanye kabini okwesithathu kuthiwe mayizi-transfer letter. I think kungcono unesi that is assisting the client afowunele la facility i-client isuka kuyo afune ngokwayo i-transfer letter. Or else, if i-transfer letter ayifumaneki, there are i-details kuthiye zikhona zala client ezitshoyo bana i-medication uyigqibele uyithatha ngedate ethile ngoku ufanele ubuya ngedate ethile. Can we at least try sisebenzise la information iphayana and izame into yokubana umntu aphathe i-ID, because we've got so many cases zomntu ofika registerishe ngam kube teste positive athathe treatment ngegama lam angasebenzisi igama lakhe. Can we try, because umntu sizamfowunela sisithi siyenza i-tracing umfowunele umntu sithi yi-defaulter athi umntu zange ndatesta positive mna. Can we at least try as much as we can ukulwa ezaa zinto, because sizaba nabo lost to follow yonke le mihla, sizoba nee-defaulters yonke le mihla, sizaba nabantu abacomplaina yonke le mihla if asincedisani nabantu. You understand? Ingase at least if uyile uphume usithi ndifumene into sisebenza phayana because we want abantu abayayo like i-patients ziphume umntu esithi I'll go back, nothi mna ndiyekile medication because I've been struggling, but xa idibene nawe mangakaphume sithi ngedate amelandelayo I will go there ndiyoyithatha ipilisi yam ndizozisela ipilisi because umntu ebendi-athendile undi-athende ngale ndlela. Ndiyadinga siyizameni. Secondly, i-stigma siqalwa sithi thina bakwa-health siqalwe ndim mna mntu uphila gabalala nesandulela before ndibe ndiyayithetha, because ndizazistigmatize mna self bana if ndiyayithetha bazothina abantu ndistigmatizile ndingekastigmatizwa. Can we try not to stigmatize ourselves so that i-HIV siyibone njengento encinci, because yinto encinci. Ixhomekeke kuthi HIV. We are very lucky uba kuthiwe we are HIV positive because ixhomekeke kum. If I do not do le nto kusuppose ndiyayenza ngendlela efaneke ndiyenze ngayo, I will get sick. The only thing you need to do is to take your medication ngendlela efaneleke, then uzawuba njengam. Andithi ke nizawuba njengam like kanjengam, but nizawuba njengam. I-organizations ezincedisana no health, they work very hard. Ingase xa zikhali organizations ku health kuvakale, because sisefieldini number one, we experience zonke ezaa zinto. Siyayiqonda basezofisini abakho sefieldini abazuba nawo mhlawumbi umbono wale nto esiyithethayo, but at least khomamele uve nengcebiso, because omnye uzawuza ezocomplaina okanye ezise i-complaint abe ezisa nengcebiso on top of la complaint. Can you at least understand laa mntu, because usefieldini uyayibona yonke laa nto yenzekayo phaya, unlike umntu othi mna ndiseofisini throughout the day andiziboni ezaa nto zenzekayo phayana. Can we work together so that izawuphela yonke into ethi people are complaining kwi-facilities abafumani olu ncedo suppose bayalufumana? Siya kwinto ye-LGBTQI andiyazi bana singayilwani njani good people, because umntu nomntu nento yakhe, umntu nomntu ne-preference yakhe, umntu nomntu ne-choice yakhe, umntu nomntu udalwe ngendlela adalwe ngaye. Ingase siyeke ukubiza abantu ngamagama, igama ongarhaleli ubizwa ngalo ingase ungalibizi omnye umntu. Or into okokuqala, sinabantu esiphila nabo ezindlini. You do not know bana lanto ugezele ngayo umntu ubudibene naye estratweni iza kwenzekela apha endlini. Ibhlungu ke thina as black people sifuna into ide yenzeke endlini ze si-understand bana into yenzekayo, which is not right. Ingase umuntu asebenzise inhliziyo enhle neclean and understand into yokubana asizudalwa ngokufanayo. Ndiyintombazana, I'm dating amadoda, but I get satisfied ngomzimba wami naxa ndijonge esipilini. You would swear ubana ndidibene nendoda, but it's because ndiye ndazijonga esipilini, I appreciated myself and ndasatisfied. There are so many different types of like there are so many things ezenzekayo emntwini ngendlela adalwe ngayo. Ingase singa stigmatize abantu singabizi ngamagama so that zizawuqheleka ezi zinto. I-communities ziyadoma ziyadomalalisa na or zisenza sizifihla izinto esizizo because baloko bestigmatize every now and then. Can we at least work together? Silungise ilizwe lethu lixhomekeke kuthi. If thina senzile into fanele ba siyayenza i-right, akho nto izawulunga. Thank you so much.
Thank you, comrade. Nzawubiza ukugqibela comrade from Treatment Action Campaign, uNongoliseko Msotyana. Nongoliseko nza kumela ngeenyawo sana. Kwenzela ba uthi yabuthi thini uthundira uthi qhaphu qhaphu.
Molweni bethunana. NdinguNongoliseko Msotyana. Ndisuka OR Tambo ePorson Jones. Ndizawumela uTAC apha. Ndiphila nentsholongwane kagawulayo, ndineminyaka engapha kwe-18 years. Andizange ndagula ndalala phansi, ndafumana i-ARVs ngexesha eli-right, ndaba right. uTAC ke waqala kude kakhulu. Kunzima, abantu sibathwala sibabeleka. Sibaseluncedweni elusikisiki. Kunzima udisclosure ngenxa endlela i-HIV eyayifike ngayo nangenxa yento bakwakuthiwa xa une-HIV uziphethe kakubi kutsho zonke izinto ezingekho right. Sasebenza singu-TAC sabancedisa abantu senza ii-support groups ze-HIV apho sibafundisa khona ukuba umuntu wamkela njani yena kuqala azakwazi ukudisclose ekhaya ezokwazi ukuba nakubanye abantu akwazi ukuthetha phandle. Abantu bavuka basukuma bahamba ngeenyawo bebelele phansi. Okwesibini ke asifuni thina singu-TAC sive into ba i-Department of Health yiyo le eyenza into ba kube khona loss to follow ngenxa ye-attitude ngenxa yendlela abantu ebaphatha ngayo gadalala. Lonto yenza abantu bangaphinde baphindele ezikliniki because umuntu uye azibone into ba akayonto yanto. Xa uzokuthiwa hamba apha lento inengculaza nina anizinakekelanga nithanda amadoda zonke izinto abazithethayo abantu ezirongo kwi-Department of Health ngokungathi amanesi zangaqeqeshwe. Loo nto singu-TAC isiphatha kabuhlungu kakhulu because amanesi aqeqeshiwe befuna babona abantu banekhe ngabantu abagulayo because bepha kulaa ndawo bakuyo nje barhola ngathi. Okunye futhi yinto yokubana sisebenze kakhulu thina singu-TAC sinceda abantu into yokubana abaphila nentsholongwane kagawulayo mabazamkele. So ngoku sibona uDepartment of Health esiphindisele ekuqaleni. Okunye futhi esikubulelayo sibulela eli xesha lento ba uRitshidze enze ixesha into abantu bayothetha izitori zabo because abantu abaninzi babhubhile okanye bafile bengakhange bakwazi ukuthetha ngenxa into beyeke ipilisi ngenxa yokuhlukunyezwa ngoDepartment of Health. And uba uDepartment of Health akayiyeki loo nto ithetha ukuthi asizuyeka uhlala sibe ne-meeting okokoko ngenxa yento ba siyahlukumezeka. Singabantu abaphila nentsholongwane kagawulayo ke ngoku sifuna into yoba nathi sibe free because samkele thina. Kodwa ke ngoku into esibetha kakhulu into yokuba ii-support groups zaphela. And uyaqaphela kule nto ka-1990 umuntu uthesta ngoku anikwe ngokwipilisi engakhange afundiswe. So abantu abaninzi nibagqibela ngoba ipilisi. Abantu abaninzi abazitya ipilisi because abazazi abazi nemiphumela yayo. Abanye babo umuntu ngose ubebeqala kwi-FDC xa sephinde etshintshelwa kule pilisi ngoyityiwayo ngoku i-dolutegravir akafundiswanga uyayiyeka. And kufuneka kufundisiwe Department of Health kakhulu because ezi pilisi zenziwa ziikhampani ezingafaniyo lento yenza into uba namhlanje ayibona iblue ngenye imini ayibona ipeach ngenye imini ayibona yenye ikhala acinga uba akusiyo. So abantu abaninzi bayiyeka i-treatment ngenxa yenu. So ufuneka nilungisile kakhulu because asiyithandi loo nto thina ngoba silwile sinikela ngamandla ethu sisenzela into abantu mabaphile nani ngababulala. Okunye futhi into ba kule nto ye-LGBTI kule nto ye-LGBTIs asiyiboni into yokubana kuqale abantu benzela ii-trainings banga-Department of Health yonke imihla besenzelwa ngoku-LGBTIs kodwa basabacazulula. Loo nto isenza into yokubana sithi uDepartment of Health akabazi ngabantu abaqeshileyo because abawazi umsebenzi wabo. Okunye futhi into yokubana all those to follow sifuna into basincedisane no-Department of Health sibakhangele because abantu bayaphela emakhaya bayafa njengoba uDepartment of Health elibele ukudlalisa. Okugqibela futhi ke ngoku into yoba ke ngoku uDepartment of Health sifuna into yokubana sicela into yokubana akhangele ii-shelters kuba abantu bayaphela kukufalela ngapha phandle. Okwesibini uthi umuntu beze iswekile yakhe iphansi inyuka iswekile le hayi inxenye uhleli phelangini. Loo nto iyababulala abantu umuntu ufike semaneni kwipilisi okokoko sokuthomakalisa i-high ngenxa yento yokuhlala phandle elangeni. So sicela uDepartment of Health enze umsebenzi wakhe acele i-donations kukhangelwe nezi shelters zingasebenziyo nakwezinye indawo kuhambe kucela donations kwenza uba kuzosave ubomi babantu. uTAC ke injongo yakhe kusave ubomi babantu. So silapha singu-TAC sithi asizuyiyeka idabi liyaqhubeka ukuba uDepartment of Health akasincedisi. Enkosi kakhulu.
Enkosi comrades, without wasting any time, sino comrade Simphiwe Sandlwana from TB HIV Care. Unfortunately, he was unable to join us physically. Sizamnika 3 minutes naye athi qaba qaba abethe kozelekazi and then emveni koko sinike kwi-department ukuthi ivale. Ingaba uSimphiwe se-ready comrades? Why we are still waiting for uSimphiwe? The department. Yeah, Simphiwe, are you connected? Yes, I am. The floor is yours. The floor is yours. Akho ngxaki qhubekeka qhubekeka.
Appreciate nale service ni provider yo elidishwa community ekutshintsheni izinto ngokwe-healthcare services. Ndifuna nje ke ukuthi mhlawumbe singacela ukuba siyiphiwe le report ukwenzela uba ii-issues ezingaphatheni specifically to TB HIV care sikwazi into yokuba mhlawumbe sizijonge kakuhle sizokwazi uba ke ngoku sibe ne-support esinokwazi ukusemba. Sisebenzisana ke kakuhle ke nee-clinics. Ndiyavuya ke ucoceka ebesithi ii-organizations ziyasebenza ngamandla siyenye ke ezo organizations ke mhlekazi. Mhlawumbi ke mandiphele kweli cala sizawuphinda sihlale naye ne-Department of Health sibonisane ukuthi zeziphi ezinye izinto esinokuzenza. Zawuyekela ke ngoku Mr. Pusende athi round up. Enkosi.
Ndiyabulela Mr. Sandlwana, ndibulele comrade yawo kakhulu ngale opportunity. Okokuqala community as well as the facility support. I've noted the recommendations that you presented, and it's one with the Department of Health. But I think I did need to start a full Ubona any Ritshidze Likoyo OR Tambo. I wasn't aware Ubana there's a local representative Ritshidze OR Tambo. I think someone the son and then ke sihlale kwakunye ne-district sigqibe ukubana siza kwenza njani going forward. I think just to respond kwezinye izinto ozibaluleke kwi-recommendations external pick-up point, I think we're doing a lot around establishing pick-up points both in facilities and out of facilities, working with isebe lezempilo. And at the same time, you also mentioned indoor assessment on Operation Phuthuma that we would need to do as well. We'll do a follow-up on that. There are endeavors that are currently underway to ensure that Sisebenzisana no national net district as well in terms of introducing the concept of Operation Phuthuma. Zininzi facilities where it has been adopted, the huddle meetings, Yahlala, net district meeting as well, ibihleli nayo recently, and there's so much support from the provincial office as well. And there were recommendations around the support with human resource, and we're doing everything within our power to make sure Indobana CI support our department in terms of deploying staff. And recently we employed a lot of temporary staff members to ensure that people are being returned into care, because the gap that we have also noted as well as UTB HIV care, that people are opting out in care, and there are various reasons care that have been documented. And I think EOS is to sit and review Leo report with you or Utata Lulapa or Tambo. So on our side, siyabulela kakhulu kokubani yena si-invite, and going forward we commit on working with you in addressing some of the gaps that have been identified. And njengoba besechilo kutata uSandlana, sawicela kakhulu report so that we can study it more closer and si-commit where we can, and ke apho singazukwazi ukufikelela khona with the hope by department izawukwazi ukufikelela, so that we can collectively be able to achieve the goal scenario. Lastly, on indoor training, we are much committed. There's a lot that we're doing on the ground in terms of doing it trainings, and get positive on our side. Kulonya kuzayo, which is starting from 1st of October on financial year where Tusizaba Nomdu, who is distinctly focusing on the training and the mentoring support in each district as he support as OR Tambo. So there's a lot that I can share and unpack in terms of our support. Hopefully there will be a follow-up session, whether virtually or in person, wherein we can share the support that we are providing. Thank you so much, Comrade Kia. Over.
Thank you, comrades from TB HIV Care. We promise that you're gonna get a soft version or soft copy of this report, and then from there, our doors will always be open for further engagements. Sabulela Maqabane, without wasting any time, unfortunately, I do not know how does the protocol department works, but we are giving to the Department of Health now. I know maybe kunabantu abasuka ku departments, but sizawunika ku department, maybe ukhona umuntu abam-identify o1 ozawuthetha on behalf of the collective, ngathi umama ngoyi.
Thank you so much, Nkokeli. Mandizibulisele kumntu wonke okhona. Mandiqale ngoku appreciate the moment and the session. On behalf of the district management, led by Mrs. Changa, the district manager, let me extend an apology for her. However, on behalf of the office yake, I appreciate the sitting. She is committed, but she knows that there is this sitting. Chairperson, you have echoed the same sentiments that you are having as the department, and more especially as OR Tambo Health District. Kule meko eti i-delivery ne-access quality health services. It's a basic human right. We also share that same sentiment. Okwesibini, let me say we welcome the findings of the facility monitoring assessments, and we welcome every word that has been shared here. We might not be agreeing with some of the things that are happening, but we are not saying azenzeki. Hence, in the city, we are welcoming the report. I am also seeing this engagement as part of us coming together ukuze sikwazi ukuya phambili. It's to me or to us from the district office, this is not a fault-finding mission, but it's actually saying, yeyele. And I'm also equally excited to hear most of us sithetha ngazwilinye to say, what is it that we can do differently from various organizations that are here? I will not be responding to the issues that are raised. However, I am also sharing the same request as UTB HIV Care to say we need time to look closely to the report so that we can be able to pick up points of action and attach responsibilities. Ngoba, we also want to see a difference in the next coming report. We would love to see a huge change. We have also noted, though, individual cases that needs urgent attention, and we are committing as the district, as the OR Tambo, ukuthi we will equally follow up and make sure that ziyaphenduleka. The likes of the issue that was raised by Usisi Yomtana Wasentshele, and also the issue of health services to la area yasenhlekiseni. Ezinye izinto might not be answered as soon as we would love to. However, there are small bites or small steps that we can take, because when you talk about chronic access to chronic medication, it doesn't even want us to have a fully fledged mobile clinic, but it's something that we can do by visiting the area, engaging stakeholders, sibone indoba what resources are there that we can leverage on. So as much as I'm committing that we'll look into the report, I'm also promising that through the district lead, Ritshidze, we will keep the communication going in terms of sharing iplane sinayo in responding to the issues that have been raised here. We are also, as the district, implementing Operation Phuthuma, and I'm also happy that part of what Ritshidze has presented is support in ensuring that we cascade the initiative further down to implement us. We have facilities that have been identified by national, Z4 epondweni, but kule 4 yasepondweni 3 yonke yase OR Tambo, which basically means ikhona into ekufuneka siyenzile differently. So we are working with those facilities. However, when we talk Operation Phuthuma, we have expanded even beyond as facilities national. All facilities as OR Tambo are implementing, however, they are in different phases. And we've even identified facilities that we're saying over and above as national, let us try to support and push them, because we want abantu Bay to be retained on treatment. We want a healthy nation. So we have expanded the exercise to more than the 3 facilities as a support of national. In terms of implementation of the new ART guidelines, 2023 guidelines, with the support of partners that are supporting, we have rolled out the trainings. We are trying to build as much capacity on the ground so that as we go out, supported by various stakeholders to create demand, at least bafikele ku platform of health workers who know what to do and when. We are even planning with the support of TB HIV Care to go beyond the capacity building of health workers, to get communities and key stakeholders, to orientate them on the changes on policy, because we want to see a space whereby we can be having also ambassadors that would be creating more awareness and education on the ground so that people can be able to get quality health services. With Operation Phuthuma, we have requested through Unoloyiso to get representatives at various levels, so that when we sit for Operation Putuma meetings, at least kube khona people from the sector who are part of the engagements. We are still waiting, ma'am, the names of people that would come. And also we have been given the name of Ucoceka Gantile as the sector lead person. We've tried to engage, but unfortunately we didn't reach her. But I'm happy that we are now attaching the name to the face, so that possibly if the contact details might have changed. What I'm trying to say is that we are open and we are welcoming all the support that we are getting, and we're also rallying for more support in terms of us ensuring that we change the picture as a OR Tambo. Thank you so much.
With those words from a department, I think on behalf of Ritshidze, Treatment Action Campaign, PHIV sector, and the public healthcare users, we note the response, and we are going to share the report with you. District manager sancokola naye about indaba ye-Operation Putuma, samneka igama likasindiswa nondiphiwe ukuthi ngabantu abazohlala pha e-districtini, and anything that has to do with reports and follow-ups, engagements, please feel free to engage with Comrade Abondipiwe, Nabo Comrade Cindy. But also it is our wish, and this is what we said kumamunokwe at the provincial level, to say, it is our wish next quarter, when we issue another report, we get feedback from the districts, so that those developments are incorporated in our reports, because it becomes difficult for us to include those developments because we are not privy to that information, and now our reports looks like one-sided. Yet if we were to be privy to those developments, we were going to be in a position to include them here, so that we can be able to reflect progress made after the engagements we had with duty bearers and the officials at the district level. Without making, and before we close, just ma'am, I've got a verbal diarrhea. I just talk. The issue of transfer letters, we need to abolish it. Because this thing of transfer letters, it makes things to be difficult for the people on the ground. As I'm sitting here, I'm asking myself, I am banking with UAPSA. And ndayivula eGovernbek ABSA account yam. But I go anywhere if I've got an issue with my money or bank account, whatever. I'm not being asked a transfer letter. I'm not. I'm just getting services. I even go to ATM, put my card. Imagine does not come back and say, where's your transfer letter? And when Dr. Aaron Motswaledi was starting the NHI pilot project in 2012, among other things he spoke about is a unique patient identifier. It is going to make things easy for the users and all that stuff, but we do not see it. We were told about tierdebt.net. If all these things were there, they were going to make our lives easy. Usiswam no comrade bame apha bathetha about efforts abazenzayo to assist people in getting transfer letters, to an extent of going to Google, calling those facilities, and I am asking myself, what is the facility doing about that? So I'm trying to say, masebenzisane songeni, in order for us to be able to improve the quality of services. But also issues around public awareness, education, informing communities about services that are available with facility, changes in the facility. People will never know about those things if our facility manager do not hold those meetings with communities, with community structures, in order for us to go back to communities and say to them, I sense a clinic, but it's only people from the department who knows about those things. And then you only know about it when you enter into a facility, which I sense the voluntary. Lastly, we've got a problem as the country. If we look at a trend on HIV infections, it is among young people. And the same young people are the ones that we made sure that they were born free of HIV 25 years ago through the prevention of mother-to-child transmission therapy. They were prevented. We made sure we fight with our government to roll out PMTCT. 20 years, 25 years, 14 years down the line, the same people are getting infected. And we must ask ourselves as the country, what is it that we are not doing well? Can we please rise so that we can close the meeting? How are we closing them? Besivule ngomthandazo. Khange sivule ngangoma. Ikhona enye ingoma enthanda icula. Andaba sayazi na. Ithi kancane sekusele kancane. Kancane sizophumelela. Hayi kancane sekusele kancane. Kancane sizophumelela. Kancane sekusele kancane. Kancane sizophumelela. Elimpopo sekusele kancane. Eastern Cape sizophumelela. Western Cape sekusele kancane. eNatali sizophumelela. Amandla. Thank you, and the meeting is closed. I'm told there is lunch also. Thank you.